main videos, it's great. If you've not done, it's okay. So if you do this one more time so that it's consolidated, and that is all you need for radiology, and we will be revising as we go along in our live sessions. Okay, so let's begin. The first thing that we're going to be talking about is general radiology, where I'll be focusing on the 4 main modalities that we have, and what are the salient features, what are the thumb rules. So thumb rules now become very important. Okay, you don't want to memorize the lists of what is the best investigation, what is the initial investigation. I want you to understand it very conceptually, that when you do what investigation, and it comes naturally to you. By the time you finish watching this video, hopefully on 1.5x maximum, don't go on 2x, because then you lose out on concepts. So 1.5x max, 1x best anyways. So whatever speed you are watching at, by the time you're done with the video, hopefully it'll come naturally to you that what investigation is to be done when. So let's begin then with general radiology. So the 4 main investigation that I'm going to discuss, just to give you an overview here, is X-ray, CT, MRI, and ultrasound. Okay, so these are the 4 main investigations that we deal with in radiology. What you hear as technetium scans, PET scans, SPECT, all of these are nuclear medicine investigation. Nuclear medicine is a whole different MD branch. It is not what I have specialized in, but I shall be teaching you nuclear medicine. There is a small chapter, you get 1 odd question from that. And radiotherapy, again being a different MD branch, nothing to do with radiology, but still I'll be covering it. For some reason, it's very small unit and you don't really get a lot of questions. So both of those we'll be looking at towards the end. In the beginning, I want to focus on diagnostic radiology. So just to give you overview of these 4 investigations, X-ray and CT are more or less the same thing. The concept is the same, that I have these rays called X-rays, which are coming from the X-ray tube. So now the X-rays are going through and through me. If I take a 2-dimensional investigation, what I get is an X-ray. But if I take cross-section, right, my computer takes these X-rays through and through the patient in a 3-dimensional manner, and now I can generate any plane which I want. I can get axial images, which are cuts. I can get coronal images, which is anterior to posterior, and I can get sagittal images, which are side to side. So 3-dimensional images using a 3D volumetric scanning of the patient is called CT. So the CT, you know, it stands for computed tomography. Tomo means to take slices. So you're taking slices, axial cuts here, or basically you are taking multiplanar, multiple planes imaging. So that is what is CT. So both of them essentially use X-rays. If I ask you which has higher radiation, CT has a higher radiation as compared to X-ray, obviously, because now I'm going through and through and it's 3-dimensional. So both of them have ionizing radiation. Both of them are going to use the same concept, and hence the density that I see, what is black on an X-ray will remain black on a CT. What is white on an X-ray will remain white on a CT. Just that the resolution becomes improved in a CT scan because there's no summation. I'm seeing a section here. So that's what we need to know here. Ultrasound, as the name suggests, uses sound waves, and these are in the ultrasonic range. We can't really hear these sound waves. No, when you get an ultrasound done, can you hear? You can't hear those sound waves because they are in the ultrasonic range. They begin when my hearing power ends. So these sound waves are in the 2 to 20 megahertz range. So they belong to the 2 to 20 megahertz range. What do you think? Will it have radiation? No, these are sound waves. When I'm talking, are you getting radiation through your phone? You're getting radiation through your phone, but you're not getting radiation through your sound waves, right? So ultrasound, remember, sound waves. Ultrasound doesn't have radiation. No ionizing radiation. That's why I can do it in pregnancy. That's why I can use this in children, preferably. MRI now is magnetic resonance imaging. Magnetic resonance. So here what I am using is a giant magnet. If you've ever been to an MRI room, there's this huge machine which is the huge magnet belonging to somewhere close to 1.5 Tesla. Nowadays we have 3 Tesla. We are going towards 5 Tesla, 7 Tesla. So higher the magnetic strength, higher is the resolution of the images. So this is the high strength magnet. Now you place your person inside this. We try and find a resonance of the frequency of the protons. In our body, we have a lot of water, meaning I have a lot of H2O, meaning I have a lot of protons. Now these protons are spinning on their own axis. I want to bring this axis of rotation equal to the rotation of the magnet. So I am finding resonance. When I do that, I get signal, I get image. So this is where I'm using the body's own protons and I'm using the giant magnet to get a signal. So this also does not have radiation. No ionizing radiation, just magnet and protons, right? So MRI actually gives me the best contrast resolution out of all of these. It gives me the best contrast and there is no radiation. So this is very, very good. Just that it takes a long time to get an MRI done. If you've ever been to an MRI machine, it takes at least 30 minutes to get any part done, right? So that's where it is not useful in emergencies because it is time consuming, it is expensive, not readily available. So it's the best, but expensive, takes time. So not useful in emergencies. So this is a perspective that you've now gotten. 2 which have radiation, 2 which do not have radiation. Now we'll see images of these, we'll understand the clinical aspect of these, and we'll see the thumb rules, okay? So let's go. So first of all, what terms will you use? I refer to it as black and white. Now black and white is not something you want to write in your report that the lesion is black, doesn't look good. So then we have to be fancy. So what are the fancy terms that we use to call something black or white? So on X-ray, you want to remember anything which is black, I'm going to call it as lucent, or I will call it as radiolucency. Anything which is white, I'm going to call it opaque or a radio opacity. Okay. CT, MR, ultrasound, all of these, it's same. If it is hypo, it is black. Hypo is the prefix. If it is white, the prefix becomes hyper. Okay. So this is simple. As soon as I read hypo, hyper, I know the color. Rest of it doesn't really matter. But just to know, on CT, now I'm going to call it hypodense and hyperdense. On MRI, I'm going to call it hypointense, hyperintense. On ultrasound, because it's sound waves is echoing. So it is hypoechoic, hyperechoic. Don't really need to remember the suffix. As long as you're not radiologists, you can just do with this and you'll get your answer. So this is about the basics. We already discussed non-ionizing. The 2 main investigations become ultrasound and MRI. So anything which is a modification of ultrasound, like ultrasound Doppler, is non-ionizing. MRI, any sequence of MRI, we will learn those, is non-ionizing. X-rays, ionizing. So one are your X-rays, which we also refer to as radiographs. So they definitely use X-rays. Then we have CT scan, computed tomography, which definitely uses X-rays. Apart from this, any study where I am giving contrast and then I'm taking an X-ray, that's called a contrast study, also called as a dye study, also uses X-ray because I'm essentially giving contrast and taking an X-ray. For example, HSG, hysterosalpingography, I inject contrast to the cervix and I take a X-ray, right? So that's contrast study, uses X-ray. Let's take an example, IVP, intravenous pyelography. I inject contrast intravenously. It is going to come to the kidney to get excreted and I take an X-ray to see the collecting system of the kidney. That's IVP. ERCP, endoscopic retrograde cholangiopancreaticography. I go via an endoscope, cannulate the papilla and inject contrast into CBD pancreatic duct. Taking X-ray after giving contrast. So you get the concept. All of these are called as contrast studies. So remember, X-ray plus contrast. So they use ionizing radiation. What is mammography? Mammography is X-ray of the breast. So mammography also uses X-rays. What else? What is the investigation of choice for osteoporosis? It is a DEXA scan. What is a DEXA scan? Dual energy X-ray absorptiometry. So this is where I calculate the bone mineral density using X-rays. So again, uses ionizing radiation via X-rays. Where do we use gamma rays? So gamma rays, remember, come from the nucleus. X-rays come from the extranuclear region, which is basically the electrons. So X-rays are coming from the electrons which are getting emitted, resulting in formation of X-rays, whereas gamma rays come from the nucleus, and that is why we refer to it as nuclear medicine. So all of your nuclear medicine scans are going to be using gamma rays. For example, your technetium-99 scans, everything with technetium, whether it is sestamib, whether it is DMSA, MDP, whatever it is, all your nuclear medicine technetium scans are going to be using gamma rays. And SPECT. What is SPECT? Single photon emission computed tomography. So just focus on SNP, single photon emission computed tomography, is a technetium scan but with a CT. So I can get 3D localization of my hotspot, right? So a comparison would be, this is the X-ray of nuclear medicine, whereas this is CT of nuclear medicine. This is 2-dimensional, SPECT is 3-dimensional. And then we have PET, so positron emission tomography. So this is where I'm going to be using positron emission now. This is also nowadays combined frequently with a CT scan, making it PET CT or PET MR, but essentially PET uses gamma rays. So this is your perspective on the imaging modalities. Just to give you an idea of the doses, don't really memorize, but the highlighted ones you should have an idea about. So chest X-ray is 0.02 millisieverts. This you definitely should remember. It's minimum radiation of any X-ray, and that's why we do chest X-ray most commonly. Other X-rays are a bit higher. Mammography, very important, is 0.5 millisieverts. This also I want you to remember. Then now compare it with CT. So see, this is 2 millisieverts. So a CT head is almost 100 times that of a chest X-ray, right? So that's how much radiation increases in a CT scan. So just to correlate, so 2, 5 and 10, as the size of the part increases, the radiation increases. PET is even more, it's 10 to 12 because gamma rays have higher radiation. Now imagine doing a PET CT. A PET CT is usually a whole body CT. So it's around 15 to 17 millisieverts here, and then it's 10 to 12 here. So almost 25 to 30 millisievert is your PET CT. It is the highest radiation of any investigation when you do both of these combined. Barium meal follow through is where you are giving barium to the patient orally and then you take X-ray. So this also is pretty high because we take a bunch of X-rays. We take these continuous X-ray exposures, and that's why the radiation increases. IVP also is pretty high compared to a standard X-ray. So this is what we need to know as a reference. Don't take these numbers to heart. Maybe just the highlighted ones. Okay. So now going on to the images, going on to the clinical aspect and thumb rules. So this is what an X-ray looks like. First things first, side. So what you need to remember here is this is right and this is left. This is going to be true for everything. Just imagine it's somebody talking to you, like I am talking to you through the video. What is my right side is what is the right side of the patient on the X-ray. So that's how you remember. This is right, this is left, and that is how it always will be. Most of the times on the X-ray, there will be a marker. If there is a marker, follow that. If there is no marker, right and left. All right, right and left. So this is what we need to know. So this is an X-ray. This is a CT scan, computed tomography. What can you observe? You can observe that, ma'am, the bones are looking white. Similarly here, the bones are looking white. The air in the lungs is looking black or lucent. The air in the lungs, when I take a section through it, is looking black. The center mediastinum is somewhere in between. It is neither white nor black. It is gray. When it is summed up on the X-ray, it may look a bit white, but still it is intermediate. So that is what you need to remember here on the radiograph and the CT, that bone and air are the opposite color. Bone is white, air is black, and that's how you're going to recognize a CT scan, differentiate it from an MRI when you see that the bones are white. So that's what we got here. Now, another point you want to remember is the difference between these two images. Both are CT scan. What is the difference? The difference are these vessels. The vessels here are appearing white. Why are they appearing white? Because I have injected IV contrast. The contrast media I use in a CT scan is iodinated contrast media. So I've injected through a cannula, intravenous cannula, iodinated contrast, and that is why all of the vessels where the contrast will go is going to appear white, whereas here it doesn't appear white. So what do? You compare it with normal muscles. Look at the muscles here. Can you see these soft tissue muscles? If it is whiter compared to muscle, it is contrast enhanced. If it is the same as muscle, we have not given contrast. So this is a non-contrast CT scan, whereas this here is a contrast enhanced CT scan. Got that? When will I give contrast? I will give contrast anytime I want to see organs, right? So anytime we are looking at inflammation or infection where the contrast intake will be increased because vascularity is increased. Anytime you want to see tumors, we will give contrast because tumors have neoangiogenesis, right? So that is where we are going to be doing CCT. Unless the thing that you want to see is white, you will give contrast. You'll understand that better. But the line is, unless the thing you want to see is already white on an NCCT, you give contrast. Okay, you'll understand that. Now look at this image. Here you can see that everything has changed. Now I'm seeing that the mediastinum has become white and I'm seeing more details of the lung parenchyma. So this is not a special CT which I have to acquire. It's just the settings, the window resolution that I change, which we call in radiology as windowing. So this is what we call as the lung window. Or what you can remember is a high resolution CT. This is what is called as an HRCT or a high resolution CT, where you start to appreciate the respiratory parenchyma, where you start to appreciate the lung parenchyma. So this is HRCT. Anytime they give you any respiratory condition, what is the investigation of choice? You're gonna say HRCT. All right. Now, I was saying something is black, something is white. When do we say that? If I ask you, are you fair or are you dark? If you are the only person living on this planet, will you have an answer to that? No, you are who you are. Yeah. But if you are living with the next person, are you fair or are you dark? You compare, right? So that's what you always do. To know something is black or white, we compare. So then what is the reference? The reference that we use is fluid. So this fluid or distilled water is what I have said is my reference. Now in this CT, you will be like, ma'am, where do I find fluid to compare? So CSF, that's why I pointed to CSF. CSF you can use as your surrogate marker because you're not going to have water everywhere. So this is what is my reference, that isse dark hai, then it is black. If it is whiter than this, then it is white. So in numerical terms, in objective terms, what I use in a CT scan is what is referred to as Hounsfield unit, that is called as HU. So what we use on imaging is Hounsfield unit, HU, wherein I have given this HU0 a reference to distilled water. That distilled water is my reference. Anything darker is a negative HU, anything whiter is a positive HU. Come to negative first. There are only two things which are negative HU. Let's appreciate this. Can you see here? This is the subcutaneous fat. This is the skin and this is the subcutaneous fat. You can see that the fat is dark and you can see that the air is black. Both of these are negative HU. Air is much darker as compared to fat. So fat, I give it an HU of -10 to -100, whereas air becomes -1000. Okay, so these are two things with negative HU. Coming to positive HU, 20 to 30 is your muscle, your soft tissue that we were using, right? So soft tissue muscle is almost equal to water, just a little bit more whiter. 60 to 90, very important, is acute hemorrhage. When we will evaluate head trauma, we will see that acute hemorrhage is hyperdense. It is whiter as compared to soft tissue. So do you agree that now when I'm evaluating acute hemorrhage, or another way of putting, when I'm evaluating head trauma, do I really need to give contrast? Unless the thing you are looking at is white, we use contrast. But this is white. So this is where I don't have to use contrast. I'm just gonna do an NCCT. Getting it? Because it is white. 100 to 300 is the contrast. It's the iodinated contrast that we are using, which is white. And the whitest of them all is calcium. Calcium meaning bone. So your bone cortex especially is what is made up of calcium, and that is the whitest thing that we have evaluated. So again, can I say that if I want to look at calcification, if I want to look at stones which have calcium, if I want to look at bone pathologies like fracture, what will I do? Do I need to give contrast? No, it's the highest HU. Why do we want to give contrast? I'm just going to do an NCCT. It's anyways going to be white. So again, I'm going to do NCCT. Something which is not even in the scale, goes beyond 1000, is metal. Now, normally I don't have metal in my body. But if somebody has a metallic foreign body or an implant or something, now this is even higher than the bone. So this is going to be very, very white. And again, do I need to give contrast? It's whiter than the bone. I don't need to. So here again, the investigation of choice is NCCT. Are you getting the gist of this? So this is what we need to remember here. So now looking at the thumb rule. So it's again something which we will go in a very fluid manner. You'll just understand it very naturally. That ye to aata hi hai. So CT. So here what you have to remember, where all will I do CT? Anything which is white. So now see if it makes sense. Calcification, calculi which are calcified, bone cortex, acute hemorrhage because it was white, metallic foreign body. So this is everywhere where my investigation of choice is going to be a CT, right? And not just a CT. Now I can also add that, ma'am, these are anyways white, so why give contrast? So non-contrast CT scan. Understanding? Right. So now let's see further into the details. What can they ask me? Calcification, they can ask me what is the investigation of choice for intracranial calcification. Any calcification, I know it is NCCT. So further delving into it, torch infections is where this really helps me. So if I see this periventricular calcification, what is this pattern for? This is a pattern for CMV, right? So V for V, periventricular calcification. Can you see this ventricles, and around it is this white calcium. So that's CMV. Whereas if you get this white spots here in the parenchyma like this that I'm drawing, that is parenchymal calcification that you see in toxoplasma, congenital toxoplasmosis. So this is where in torch infections, this really helps me, right? Calculi. So now when I ask you what is the investigation of choice for renal calculi, ureteric calculi, or even salivary stones, all of these are stones which are calcified, you are going to say NCCT. The only exception here are gallstones, because gallstones are not calcified. You know, gallstones have pigment, they have cholesterol, but not calcium. They are radiolucent. So that is why, that is where our investigation of choice is going to be ultrasound. So you want to remember all stones except gallstones. Answer is NCCT. Look at this CT scan. This is a coronal view. Can you all appreciate that there is a stone which is white, hyperdense on the which side? Left side. And you can appreciate this is the ureter. So there is a left ureteric stone that we can see here, resulting in hydronephrosis. You can see this kidney swollen compared to the right side. So this is how a ureteric calculus will appear. So this is a left ureteric calculus. Okay. Next, bone cortex, especially fracture. So if they ask me what is the investigation of choice for fracture, it's always a CT scan. The first investigation for a fracture is X-ray, but the best investigation is a CT scan, especially in complicated areas like the spine where X-ray might not be reliable. I do a CT scan to evaluate. Can you appreciate there is a fracture of this particular vertebra? All right. So for fracture, the best is a CT scan. Now, when we talk about bone tumors, for all tumors, the investigation of choice is MRI, okay, because we want to see the marrow involvement. The only exception here, which is a cortical-based tumor, what is it? This is an osteoid osteoma. So osteoid osteoma is the only cortical-based tumor. It has this nidus, this lytic lesion or this lucent lesion that you are seeing here, or this hypodense lesion is the central nidus which produces prostaglandin E2, resulting in pain. So we'll talk about all of that. But osteoid osteoma is the only cortical-based lesion where my investigation of choice is a CT. Everywhere else, it's going to be an MRI. Talking about acute hemorrhage now. We saw acute hemorrhage is white. It's hyperdense. I need not give contrast. So I can also say that for head trauma per se, where hemorrhage is the main consideration, the investigation of choice is an NCCT. So look at this CT scan. Can you see this white color hyperdense hematoma? So we see the shape. If it is biconvex, this is EDH, we'll talk about all of this. This is extradural hematoma. If it is banana or crescent shaped, it is a subdural hematoma, right? So this is EDH versus SDH, investigation of choice, again NCCT. Metal. So now appreciate this image. Can you see? There was a carpenter doing something and a metallic shrapnel went into his eye. So can you appreciate this, that it is not just white, it is whiter than the bone, isn't it? So this is where obviously the investigation of choice is NCCT. Not just that. What is it that I can never do which will be harmful to this patient? MRI, right? Magnetic resonance imaging. Imagine putting a metal in a giant magnet. Your patient is going to have impact and will be harmed. So MRI is absolutely contraindicated. If you've ever gone to an MRI, we're first going to be screening the patient. Did you get some dental implant? Do you have any bullet in your body? You know, so basically you have to rule out metal from the patient. Otherwise, you can't do an MRI. The best investigation is a simple non-contrast CT where the metal will shine out. Is this clear? If you ask me, ma'am, what is first investigation? See, remember the thumb rule. Wherever CT is the best, X-ray is the first, because X-ray will tell me, okay, something is white. Now you do a CT and figure out where exactly it is, right? So always wherever we are seeing all of these, the initial is X-ray, best is CT. Right? So this is our thumb rule page, very important page for CT scan. Just to finish off foreign body perspective right here, right now, they keep asking you this. There are these two children who have either swallowed a coin or aspirated a coin, and it's your job to find out whether it's in the esophagus or the trachea. So what do we do? What you have to see is the face of the coin. If you can see that the complete face of the coin is seen, this is esophagus. So if it looks like this, it is esophagus. Whereas if it looks like a slit, It is in trachea. Why so? Because you know that trachea is this C-shaped cartilage. Your coin can't go like this. It will have to live like this because of the cartilage. So that is why the trachea is going to show you the slit, whereas esophagus is distensible. So it will show you the full frontal face. Okay. So this is how your coins will appear on esophagus and trachea. On the other hand, what is this here? So you can see now that there are two rims, right? Can you appreciate? Now try and appreciate. Can you see that there are these two rims here? When you see such a beveled margin, this beveled margin is what is a feature of a button battery. Have you seen these tiny button batteries which look like this? So this is three-dimensional, isn't it? So that's why on an X-ray, you're going to be seeing this beveled margin because it's a summation. It's a two-dimensional summation of the same. So a button battery will show you this beveled margin. Last INICT question. Right? So this is about the approach. Now they can ask you what will you do next. It's more ENT domain, but just to finish it. So here, anytime you have a button battery, you just need to remove immediately. Irrespective of where it is, you have to remove because these button batteries have alkali. Alkali, you know, L for liquefactive necrosis. So this is what is the result and that's why you need to remove it immediately. On the other hand, a coin. In the trachea, again, you have to remove. You're going to remove it with a rigid bronchoscope because rigid bronchoscope, therapeutic, flexible bronchoscope, more for biopsies, more for diagnostic procedures. So remove using rigid bronchoscope. Whereas if it's in esophagus or GI tract, now you need to see the position. If it is stuck here, right? If it's stuck in between the esophagus, then you have to remove it with upper GI endoscopy. But if it is in the stomach, if it has reached the stomach, now you can wait and watch. Okay, because the narrowest part of the esophagus is cricopharyngeus. If something can cross the cricopharyngeus, it can cross anything in life. Yeah, so you just let it. So you let it be. Wait for a few hours, wait for 24 hours, it will come in the stools, right? So that's what you have to do. If it's reached the stomach, wait and watch. If it's anywhere above it, you remove it. So this is about your approach to foreign body. Next, we talk about MRI. As I said, MRI is magnetic resonance imaging. So now we are delving into the sequences. So now talking about the sequences here. So what you first need to remember is a sentence that is, or a word that is World War II, or a phrase that is World War II. What do we mean by World War II? Water is white on T2. Now, these are all brain MRIs. First of all, you'll be like, ma'am, what, why? Why is it MRI? So then what will I tell you? I will tell you, look at the bone in all of these. Can you appreciate the bone here? So when you see the bone is black, it's MRI. When you see the bone is white, it's a CT scan. Don't look at this white rim around it. That is not the bone. That is the fat. Do you have bone outside? No. You have scalp fat, and then you have the bone, right? So this is the scalp fat that you see, and then I have the bone. So one observation that I can make is that fat is always white. Whatever be the sequence, fat is white. I'm going to use this up arrow to indicate hyper intensity or it being white, and you will understand. Okay. Whereas bone is dark on all of them. That's how I know it's MRI. So once I'm done that it is an MRI, now I have to see the fluid. I have to see the CSF. In the brain, we have CSF in the ventricles, right? So we now look at the ventricles. You can see the ventricles are white here, whereas they are black in these two. So as soon as I see water is white, it is T2. So this is our T2 weighted image. Okay. So this is T2. Whereas if it is dark, now it can be two things. For that, I now need to appreciate the gray matter and white matter. Look at these two images carefully. Here you can appreciate that the cortex is darker or gray and the white matter is white. So, gray matter is gray, white matter is white. It follows the name. Whereas on a T2 weighted, it's opposite. You can see that the white matter is actually darker. It is gray and the gray matter is actually whiter. It is white. So what you will remember, you'll not remember both. Don't remember both. Remember one, right? So gray matter is gray, white matter is white. That is what is T1 weighted sequence. Is this making sense? So now first let's finish T1, T2. On T1, fluid is dark. On T2, fluid is white. World War II. Gray matter is gray and white matter is white on T1. Without thinking, I just make this opposite. So far so good. Now look at the third image here. On the third image, can you appreciate that the water, the CSF is dark? Meaning, is it T1 or is it something else? Let's confirm with the gray matter, white matter. So here you can now appreciate that the gray matter is actually whiter and the white matter is actually darker. So this reminds me of T2, isn't it? So this is T2 where I have suppressed CSF. So such a sequence where the fluid is dark but gray matter, white matter resembles your T2 weighted sequence, that is what is a flare sequence. Flare sequence means fluid attenuated inversion recovery. Fluid attenuated. I have attenuated the fluid by inversion. You don't need to remember the full form. You just have to remember that this is T2 weighted minus CSF. I have suppressed the CSF signal intensity, rendering T2 as it is minus CSF. Why, ma'am? Why did you do all this? I'll show you why. So look at these images. So if, let's say, I have some sort of pathology, any pathology has edema. So edema is fluid. So fluid is white on T2. So let's say this is my T2 and I have a pathology here. It will appear white and I can pick it up on a T2. I can pick it up on a flare just fine. But then what if I have a periventricular white patch? Seen usually in multiple sclerosis, which is periventricular. Now on T2, I might just miss it because then it's so close to the fluid. But then when I do a flare sequence, now this shines out. So flare is the best for picking up pathology. Can you appreciate this now? That whatever is the edema, whatever is the pathology just shines out because I've suppressed the CSF. Unnecessary whiteness of CSF I have suppressed while keeping the whiteness of the pathology. That is edema. Understood? So flare, what is the only difference? The only difference is that the fluid here is dark, whereas gray matter, white matter is just like a T2 weighted sequence. Clear? So it's T2 minus CSF. And fat we saw is white on all. So now you'll be like, ma'am, if fat is white and edema is white, how do you expect me to pick up bone marrow edema? Because bone marrow has fat, right? Bone marrow you all know is yellow fat. So now if fat only is white, how will I pick up white edema? So you're like, okay ma'am, you killed CSF once, you are a killer, you kill fat. I kill fat. So this is what you need to remember. This sequence is stir sequence. Stir sequence is T2 weighted minus fat. So now I'm suppressing the fat signal intensity. Getting it. Why are we doing all this? Because bone marrow fat is white. Now if I want to pick up bone marrow edema, I gotta suppress my fat signal intensity so that anything which remains white has to be bone marrow edema. Clear? So bone marrow edema, the sequence is STIR. STIR stands for short tau inversion recovery. You don't need it. Just want to remember that this is my best investigation or sequence for bone marrow edema. Next, we go on to some brain special sequences. When you see these black dots here, this is called as SWI, which stands for susceptibility weighted imaging. This comes under the spectrum of images that I call as gradient echo images. Don't need to bother about it. Just remember gradient echo, where I write as T2 star. So this T2 star or gradient echo subtype is susceptibility weighted imaging. This is my best sequence for picking up micro bleeds, small bleeds will appear as these black dots, which I refer to as blooming foci. So these black dots are blooming foci, microbleeds that you see in a condition called diffuse axonal injury. We will study about this. For now, you remember that these black dots are chota bleeds, microbleeds seen in diffuse axonal injury. Next two set of images. First of all, how to identify this is DWI, diffusion weighted imaging. You will not see any of the bone, the fat, nothing. You directly see the brain. DWI we usually do with another sequence called ADC. It's not a special sequence, it's just a derivative of DWI. So this is diffusion weighted imaging, whereas ADC is apparent diffusion coefficient. You don't need it, hence not writing. So DWI, ADC. Anything which is doing diffusion restriction. What I'm trying to pick up here is the diffusion restricted or not? So if something is restricting, it will be hyper intense or white on DWI and hypo intense or dark on ADC. That's what we call as a diffusion restriction. White on DWI, dark on ADC. At your level, you can also remember white on DWI is diffusion restriction. Now, the big question is, who will restrict diffusion? For that, I need to teach you the concept. So here what you will remember is, let's say this is a set of tissue. A tissue has multiple cells, right? And you know Brownian motion. Water is diffusing here randomly, and this is normal diffusion, which is unrestricted. Now, imagine somebody having an ischemic stroke. In ischemic stroke, what happens? The blood supply is cut off, your sodium, potassium, ATP pump stops working. Because of which, now what happens? Now your cell is gonna swell up, right? Because your sodium and potassium flow is blocked. So this edema is called cytotoxic edema. So now what happens? My normal cells were like this. Here my cells have now swollen. So now what do you think will happen to diffusion? The diffusion is restricted. So this is first example of diffusion restriction, which is stroke. Kaisa stroke? Ischemic stroke. So ischemic stroke will show diffusion restriction. Second, imagine I have a hypercellular tumor. So now again, as compared to normal, I have so many cells. What will happen? Diffusion restriction. So tumors which are hypercellular will show diffusion restriction. Another example, anything which has pus. Now there are no cells. It is just thick pus. Will there be diffusion restriction? Yes. So abscesses will show me diffusion restriction. And one last example, let's say I have a cyst which is filled with this thick keratin-rich fluid. Example, epidermoid cyst. So epidermoid cyst will also show me diffusion restriction. This is frequently asked as a versus question on arachnoid cyst. Arachnoid cyst does not show me restriction, whereas epidermoid cyst does. So what are my conditions that show me diffusion restriction? Ischemic stroke, best and most important. Tumors, abscess and epidermoid cyst. So my takeaway of diffusion restriction in one line, you now know the concept, so you know this, but in one line, most important, this is my most sensitive sequence for picking up ischemic stroke. Anytime somebody has ischemic stroke, diffusion weighted, can pick it up as early as 30 minutes after the insult. It's just that it is an MRI, and we said that MRI is not readily available. So we will actually understand what is the protocol for stroke, but at this point you want to remember that even though this is more sensitive, it's not something I do in practice unless I'm working at a specialized stroke setup, okay? Then, what is this color? Suddenly in black and white world, I see some color. So when you see this color coding of the white matter tracts, such a sequence is called DTI. DTI stands for diffusion tensor imaging. So this is what is used for the color coding of the white matter tracts. All right, so this is for white matter. We can use it in tumors when we want to see whether it invades white matter, it displaces what is going on. So that's DTI for you. Clear? Thumb rules for MRI. Now, anything in the brain, remember, anything in the entire central peripheral nervous system, it is MRI. So for your brain tumors, spine tumors, neurogenic tumors, everywhere, neurogenic tumors meaning neurofibroma, schwannoma, all of these we are going to be doing MRI. Investigation of choice, MRI. For most brain pathologies which aren't emergencies like stroke, I am going to be doing it MRI. Very, very important. Now, when we talk about CA lung, yeah, CA lung, you will say, ma'am, respiratory means HRCT, means CCT. Be like, yes, very good. But there is an exception. There is something called as Pancoast tumor. This Pancoast tumor is a superior sulcus tumor which can invade the nerves, the sympathetic plexus, the brachial plexus. So then what do I need to do? So this is the only exception where MRI is investigation of choice. Next concept, bone marrow edema. What did we understand? That the only thing, anytime I hear cortex of the bone, it is CT. But anytime I hear bone marrow, not just marrow, anytime I hear bone marrow, what is going to be my investigation of choice? It is going to be MRI, right? So now what are the applications of bone marrow edema? Anytime I want to see acute osteomyelitis, or I want to see, let's say, sacroiliitis, any inflammation starts from the bone marrow. Let's say stress fracture, very important. All fractures, investigation of choice is CT. The only exception is a stress fracture where you may not have a cortical breach and the only finding there is a bone marrow edema. So again, for all of these, MRI STIR sequence. Remember, we know the sequence as well. It's the STIR sequence which is best. Now, as far as orthopedics is concerned, cortex is CT, marrow is MRI. Not just that, for seeing ligaments, cartilage, soft tissue, for all of this, remember, the investigation of choice will be MRI. Fine. So for all of the others, ligament, cartilage, soft tissue, it's MRI. So this is all about MR. Going on to our fourth modality, that is ultrasound. Ultrasound, sound waves. Two main things I want you to understand here. In ultrasound, first of all, the brightness that you see, something is black, something is white, all depends on the reflection of the sound waves. I send sound waves in my body. Are they absorbed? Are they reflected? All of this will decide what kind of a brightness I see. So this mode of ultrasound that we do normally, that I just call as ultrasound, is what is my B mode ultrasound or a brightness mode ultrasound. Now, two effects I want you to learn here. First, we are talking about the gallstones. So see this is the gallbladder, this is the liver. You'll understand in some time. Within the gallbladder, there is something white. That's my stone. So imagine this is stone and sending my sound waves. This stone, very densely packed, is either going to reflect all of the sound waves or it's going to scatter it. Basically, it doesn't let anything go behind it. So what is this going to result in? This is what is going to result in a shadow behind it. So that's what you want to remember, that whenever you see this shadowing, this is what we refer to as stones. So shadowing, also called as posterior acoustic shadowing, but you can only remember shadowing. We see this in stones. All stones will show this, but it is particularly useful in gallstones because they are radiolucent and no other modality will show it to me. So that is stones. Apart from this, shadowing can also be seen in bones because bones are densely packed with calcium. There will be a shadow behind it. And then even air can show me shadowing. But air tends to show me not a dense shadow, but what we refer to as a dirty shadowing. It refracts the sound waves. So you can't really see air, on an ultrasound, and that's why we call that air is my enemy of ultrasound. Anytime air comes into picture, now my ultrasound is useless because the sound waves can't travel, right? So that is what is the concept you want to build here, that shadow seen in stones, bones and air. Air is enemy of ultrasound. Now opposite concept runs with fluid or water. This is a breast ultrasound. You don't need to know that. But there is a lesion here, which is completely black. What do we call such a black lesion? We usually call hypoechoic. But this is so black that it is no echo only. So we made a special term called anechoic. So this is anechoic. And now imagine there is a cyst. It has pani, it has water, fluid, jol inside it. Okay, so there is water and now my sound waves are going through it. Fluid doesn't want anything. It's like go through me. Yeah, so it is allowing all the sound waves to go through it, resulting in this brightness behind it. Absolutely opposite of stones. This is so generous. It's like go through me, have enlightenment behind me. So that is what we see. So anechoic with posterior acoustic enhancement is what is the hallmark of fluid or fluid containing cysts. So this is what is the hallmark of a cyst, that it will be black with posterior acoustic enhancement. Having said that, any fluid is going to be the same. So look at this. This is a fast ultrasound. We'll talk about that. So liver, kidney, you have this fluid, black fluid. So you want to remember fluid will be black, fluid will be kala on ultrasound, and echoic, right? So for anything fluid, what is my investigation of choice? Ultrasound. Whether they say pleural effusion, pericardial effusion, ascites, whatever it is, ultrasound. Clear? So two concepts, shadowing and enhancement. Next, we talk about Doppler. So this is my standard B mode ultrasound. On this, the blood vessels are going to look like this. They're going to be a tubular anechoic channel. Now, when I turn on my Doppler ultrasound, the blood vessel picks up color. So this is what I call as my color Doppler ultrasound, because now there are two things. There is B mode and color Doppler. I refer to this as a duplex ultrasound. Whereas if I put a box and now it also gives me the velocity of the blood in different phases, that ye systole hai, then diastole, ye systole hai. So if it gives me the velocity also, this is what I refer to as a spectral Doppler ultrasound, because it gives me the velocity, and that is what we call as triplex, because now you are seeing B mode, color Doppler and a spectrum. So this is triplex or spectral Doppler. Now further details, Doppler shift. What is Doppler shift? I think you have studied this before you became a doctor. That let's say I am a stationary person. There is an ambulance approaching me. When the ambulance approaches me, it gets louder, and as it goes away, it becomes less louder. Why does this happen? So any moving object, depending on its direction, will have a frequency shift. So when the blood is coming towards me, let's say I am the probe, and ambulance is now blood, RBC. When the blood is coming towards the probe, the frequency is positive. When the blood is going away from the probe, the frequency shift is negative. So that is what I code with color. Positive frequency shift means it is coming towards me and I give it a red color. If it is negative frequency shift means it's going away from me and I give it a blue color. That is how Doppler ultrasound actually tells me the direction of flow. Did you understand? So this gives me the direction of flow. How do we color code it normally? So red is towards the probe, whereas blue is away from the probe. Clear? When we talk about spectral Doppler, now this is going to tell us the velocity of the flow also in different phases. How is the velocity in systole? How is it in diastole? So let's look at the Doppler waveforms. Two kinds of waveforms you want to understand. Look at this. Peak high in systole, reversal in diastole, and then there is one more peak. So there are three peaks that you are seeing. Such a waveform is called as a triphasic waveform. Such a triphasic waveform you are going to see in the normal extremity arteries. So your normal femoral artery, normal popliteal artery, all of these should show you triphasic. If there is any narrowing, peripheral arterial disease, the triphasic waveform goes. And that is why the first investigation that I do for peripheral arterial disease is always a Doppler ultrasound to see whether the triphasic waveform is maintained or not maintained. Understood? So this is the first investigation for peripheral arterial disease. Now look at this. You see that the direction is in one phase. It is not going above or below. So such a waveform where it stays on one side is monophasic waveform. This is what we see in normal veins. Veins have no systole, diastole. They are carrying blood back to the heart. So veins have a normal monophasic waveform, right? So that is what you need to remember here. So now with that itself, let's understand what will happen in deep vein thrombosis. So first of all, when we talk about the B mode ultrasound, right? Imagine this is my probe and there's an artery and there is a vein. When I compress with the probe, the artery being elastic will remain as it is. But when I compress, my vein will disappear. So this is what happens when you compress. The artery stays as is, but the vein collapses. So if it is compressible, that is a normal vein. But now imagine this vein having a thrombus. Will it compress? Now it will not compress. So in deep vein thrombosis, what you have is a non-compressible vein. Let's talk about the flow. This is the normal flow that you see here. Fine. So this is my normal monophasic flow. But if the vein has thrombus, will there be flow? Now there will be no flow. So in a DVT, there is absent flow. So that is how we diagnose DVT. And for this reason, for deep vein thrombosis, investigation of choice is Doppler ultrasound. Clear? So this is normal vein versus DVT. Now let's talk about the thumb rules for ultrasound. As we saw, gallbladder stones, or for that matter, anything in the gallbladder, remember investigation of choice is ultrasound. So when they ask you gallstones, you know this is the only exception where CT will not help. It's ultrasound. When we talk about acute cholecystitis, inflammation of gallbladder, again, ultrasound is my best investigation. When we talk about a GB polyp, anything gallbladder, we will diagnose it with the help of ultrasound. We saw fluid and cyst were anechoic, posterior acoustic enhancement, investigation of choice, always ultrasound. So whether they ask you pleural effusion, pericardial effusion, ascites, any of it, what will be your investigation of choice? Ultrasound. Pregnancy, the first investigation, the first line is always ultrasound, no ionizing radiation. MRI in a pregnant female becomes difficult. It can be done, but it's used as a problem-solving tool. For anything else, we're going to be doing ultrasound. Vessels is Doppler. So we saw DVT, deep vein thrombosis, investigation of choice is Doppler. For varicose veins, investigation of choice is Doppler. What is this here? So you can see that this is the Mickey Mouse sign. This Mickey Mouse sign is what is seen at the saphenofemoral junction. Saphenofemoral junction is the junction where the great saphenous vein is going to enter the common femoral vein, and this is where we have a valve. So the normal direction is this, where the great saphenous vein enters the common femoral vein, and this is my artery here. So we already said that I can comment on the direction using Doppler. So if the direction is this, it's normal. But what if the valve is incompetent and blood goes back to GSV? That is where I have varicose veins. So for SFJ incompetence, Doppler is the best investigation, right? So that is why for varicose veins, Doppler is the investigation of choice. Coming to arterial diseases now. So when we talk about arterial diseases, as we discussed, the first investigation you will do in anybody suspected to have vasculitis, peripheral arterial disease, we are going to be doing a Doppler ultrasound. That will tell us that, okay, triphasic is not there, it's become biphasic, it's become monophasic, we'll know that something is wrong. What is the best investigation now? Best investigation is a CT angiography. You are now going to do a CT scan after giving contrast. So that is where now I will see. Again, the contrast is IV. It's not in the vessels, okay? CT angiography is just a CCT where I time the scan such that the vessels have the maximum contrast. That is all it means. So now I'm going to evaluate the vessels in 3-dimension view very nicely. I can see calcification. I can see the exact length of narrowing and everything. So that's why CT angiography is the best. But if they ask you what is the gold standard, the term gold standard refers to something which is not just diagnostic but also therapeutic. And that is DSA. What is DSA? It stands for Digital Subtraction Angiography. So this is where now I puncture the femoral artery. I take a catheter and I go inside the vessel, and let's say this is the narrowing I find. So I find this segment of narrowing. Now with my catheter itself, I can take a balloon. I can inflate a balloon here and I can dilate this part. I can remove the atherosclerotic plaque. So this is where this angiography is not just diagnostic, it is also therapeutic, because I can also do balloon angioplasty. Okay, so understand the difference between a DSA and a CT angiography. CT angiography is diagnostic. You don't have to do any invasion here. Whereas DSA is invasive. You're going inside, but it is therapeutic. Fine. So this is what is about the concept of ultrasound. Next, we talk about contrast media a little bit. So iodinated contrast is what you use in your contrast studies, right? For X-ray, it is the contrast that I use in CT for IV injection. So the route is IV, or for that matter, any route, right? So in contrast study, you can give it in the cervix, CBD, wherever. So any route is fine for iodinated contrast. What is the prerequisite? I need to get a renal function test done. RFT has to be normal. I will not use it in patients whose GFR is less than 30 ml per kg per body surface area. So this is not used. It is contraindicated in patients with severe renal function impairment. Why? Because iodinated contrast in itself is a nephrotoxin and it leads to contrast-induced nephropathy, CIN. It damages the kidney. So the definition of contrast-induced nephropathy is if I have acute kidney injury within 48 hours of contrast injection. You gave contrast for a CT scan and you have criteria of AKI being met within 48 hours of injection in the absence of any other cause. That's the definition of CIN. Alright. What is gadolinium? Gadolinium is an MRI contrast agent injected via IV route only. This is also where my RFT needs to be normal. We'll be doing a renal function test. This is contraindicated in CKD because it leads to NSF. What is NSF? NSF stands for nephrogenic systemic fibrosis. If you give it in a patient with renal failure, this gadolinium chelates are not excreted. They accumulate in the skin, leading to fibrosis. So that is what results. SonoView, as the name suggests, is an ultrasound contrast agent which can also be given IV. The unique thing is this is the only contrast agent which is safe in renal failure. So this is something which is actually made up of air bubbles. These are most commonly sulfur hexafluoride micro bubbles. So these are micro, small gas bubbles which I'm injecting in the IV stream. What they'll do is they'll increase the reflectivity of the sound waves, hence giving us contrast. But it is safe in renal failure because it is air. So it's excreted via the lungs, right? So that's why very important. If I have a patient with CKD, I can't use iodine, I can't use gadolinium. The only thing I can do is a contrast enhanced ultrasound, a CEUS, and that is what is SonoView. The prerequisite, because it is sulfur, you have to rule out sulfur allergy, right? So rule out sulfur allergy because you are injecting sulfur. Coming on to barium sulfate. Now, barium sulfate, remember, is what I use with an X-ray, and this can never be given IV. It's a thick paste. You can remember, like a white thick paint is what we are going to ask the patient to either take orally or as an enema. The rule with barium is it has to remain inside GI tract. If it comes out, it will lead to peritonitis. So this is what is very important, that you have to do a chest X-ray PA erect view prior to doing a barium sulfate, because this is contraindicated in any case of perforation or intestinal obstruction. So perforation, obstruction are contraindications of barium sulfate. Very, very important. Not just that, it is also contraindicated in tracheoesophageal fistula. It'll go into the lungs. We don't want that. It is also contraindicated in post-operative patients, because then they can have this leakage. So that's important. What can I use in these cases? Can I use iodinated contrast? Yes. So in all of these, iodinated contrast agents are going to be safe. That is the learning point here, that I can give iodinated like gastrographin, iohexol, whatever they give, that's safe, not barium, right? So this is a very, very important table. Now that I'm talking about these names of iodinated contrast agents, let's just figure this out. So there are 4 categories of iodinated contrast media. First, we divide them as ionic or non-ionic. Then we see whether it's a monomer or dimer. Now, these iodinated contrast agents, remember, occurs as a unit. Let's say this is my functional unit of iodinated contrast agent, which is a benzene ring with 3 iodines. This is ionic. So anything which is ionic will be with another pair, let's say sodium. So in any ionic media, I am having 2 particles. One is this contrast, one is this sodium. So this is where ionic will have 2 particles, whereas non-ionic is a single particle in itself with these 3 iodine rings. Is that clear? So this helps us understand, never memorize this, just understand iodine particle ratio. So first of all, as soon as I see that it's ionic, how many particles should I write? I have to write 2 particles. As soon as I see that it is non-ionic, how many particles? 1 particle. So that's the first half. Now, in any monomer, there are 3 iodines, right? 3 iodine per 1 monomer. So in a dimer, how many iodines? 3 2s are 6. Very good. So here in a monomer, there are 3 iodines. In a dimer, 6 iodine. Again a monomer, 3 iodine. Dimer, 6 iodine. So this is how you get your iodine particle ratio. Now you see the lowest iodine particle ratio is here, meaning this is very, very high osmolar contrast agent, almost in the range of 1200. These two are the same ratios, 3:1. So they have the same osmolarity, which is 600. Now when we had 1200, we used to call it high osmolar contrast media. So my ionic monomer are my oldest category, which are high osmolar contrast media. Then I made these and I called them low osmolar contrast media. So these 2 categories are low osmolar, and then we developed 6:1. Now low was already taken. So then they were like, okay, this osmolarity is 300, which is pretty similar to our plasma. So let's call it iso-osmolar contrast agent. Now, because this is iso-osmolar, has the best iodine particle ratio, this is what is the best for renal failure. In any patient who has any renal derangement, right? Obviously, we will never use it beyond 30, but if you have a high risk factor where the GFR is more than 30, like somebody who's diabetic, somebody who has hypertension, so somebody who has deranged renal function but is not yet a contraindication, the one we will prefer is non-ionic dimer. Now, how to remember the names? Anytime you have too much to remember, my rule in life is see the shorter list and remember that. Same we'll do here. There is only one ionic dimer, which is ioxaglate. Something common to all ionic agents is the name will end with 8. So this is ioxaglate. any other 8 is going to be monomer. Similarly, non-ionic, the name will end with all. Iodixanol, the name itself tells you it's a dimer. So iodixanol is my non-ionic dimer. Anything else is my non-ionic monomer. You don't have to see. Is this clear? So this is all about the contrast agents. Just 2 names you can remember. This diatrazoate you see as an ionic monomer is what we use as gastrographin. It is used in place of barium when you have a contraindication. What we use most commonly for CT scan is iohexol, which is a non-ionic monomer. Iodixanol, we don't really use it very routinely because it's expensive. Fine. So iohexol is most commonly preferred. I hope this is sorted. Let's quickly look at the PYQs of this section. All of this you would know, so I'll be rushing through it. Which contrast agent is safe in renal failure? So ultrasound contrast agent we saw. Identify the correct statement. HU of water is 0. Already knew that. CT is the initial investigation of choice for gallstones? Never. It is the initial investigation of choice for other stones like renal, ureteric, salivary, right? So that's what I need to know. It's not even the initial, it's the best investigation. So CT is the best investigation for stones. Initial would usually be X-ray or ultrasound. Radiation exposure in CT is 20 millisieverts. Now this is very non-specific. Which part, what are you asking? So doesn't make any sense, but you remember that head is 2 millisievert, thorax is 5, abdomen is 10. None of it is 20 anyways. CT uses non-filtered X-rays. That's also wrong. We filter the low energy X-rays so that they don't, we filter the low energy X-rays so that they don't contribute to extra dose. Fine. So here one clear-cut statement, you know. 28-year-old woman, headache, is going to undergo a CT scan. What will you ask her? Cochlear implant history is relevant for MRI. Nowadays, even cochlear implant is not a contraindication for MRI, but still you will ask this for MRI. History of fall and hypertension, you will ask anybody, but that does not indicate or contraindicate anything. LMP is very important because I will not want to do a CT scan in somebody who is likely to be pregnant, right? So we always take history in a female of the last period before she undergoes X-ray or CT. But on the same lines, you want to remember that if somebody is accidentally found out to be pregnant after undergoing an X-ray or a CT, what will you do? Will you do an MTP for her? What will you do? Nothing. Nothing needs to be done. Conservative management, even if there is accidental exposure, because it's a very low dose. Even if it's a CT scan, the dose is not enough to cause teratogenicity. There are many papers on this, and you know, as a consensus, anything which is above 50 milligray is what is considered to be harmful, and this is a radiation that we see in nuclear accidents, not a dose that we see in diagnostic radiology. So this is where if you have accidental X-ray or a CT in a female who later was found out to be pregnant, we'll still not do anything. We'll just counsel her. Having said that, don't do if preventable. So always take history of LMP. What is this investigation? Pretty easy. This is thyroid. You can see this is the butterfly thyroid. You can see the trachea. So this is an ultrasound. Now, going on to rib counting, something that students face a lot of problem with. This is the last time you'll face a problem with this. So see the method here. You just have to find out what ribs you can see. Okay, I'm going to teach you the method which is foolproof. So the first thing first, right side or left side. So this is right side, this is left side. Second thing, anterior or posterior. So you can see, we know the ribs, right? They are horizontal behind and then they take a curve and come anteriorly. So my posterior ribs are going to be horizontal ribs, whereas my anterior ribs are going to be these curved ribs. Can you all appreciate this, everybody? This is anterior, whereas this is posterior. So that's the first thing. So when I ask you what is the highlighted rib, half answer you already know that, ma'am, it is horizontal, so it is right posterior. Now which one? So for this you start counting from what you see. Ignore this small one, even if you see it. You start with the big ribs. So you will be like, ma'am, okay, 1, 2, 3. So you count like how you normally would and you add 1 to it. So you did 1, 2, 3. Now add 1 to it. It becomes right fourth posterior. So that is what you have to do. Let's take an example. You can just stop this video for a second here, pause it and calculate what is the highlighted rib. Pause and do yourself. So first of all, you will tell me that, ma'am, it is definitely left posterior, and then you started counting. How did you do? 1, 2, 3, 4, 5, 6, 7. And then you added a rib. So 7th ki jagah 8th. So that is what you have to do. One more example. Pause your screen and do this. Right posterior. 1, 2, 3, 4, 5. 5 plus 1, 6. So this is right 6th posterior. Clear? So that's all you need to do. No more seeing this topic again. Whole body CT scan is done in patients, who have polytrauma. It includes head, abdomen, C-spine, but not the limbs. So what we do in the whole body CT, somebody who has very severe trauma, is first I will do NCCT head along with C-spine, and after that we do a CCT. We do a CCT of the chest and the abdomen, right? So this includes the entire body. The limbs are only included if there is any trauma to any particular limb. Now talking about pacemaker and aortic valves. So see this, there are 3 kinds of pacemakers. If you see a single lead pacemaker, that lead is in RV. It's like a step-up approach. If you see 2 leads, it is in RV plus RA. If you see 3 leads, it's a biventricular pacemaker where it is in RV plus RA plus LV. So RV is always going to be there. If I see 2, the second one is in RA. If I see 3, the third one is in LV. So now see this. This is the subcutaneous generator of the pacemaker. And you can see these are the 2 leads. One here, one here. Now, where is the lead? So the shorter one, what do you think, is in the RA? The bigger one is in the right ventricle. So this is how you know RA and RV. Look at the options, only one of them. So RV is the answer, right? So pacemaker is sorted. Now we go to valves. So how to know whether a valve, if they label this and ask whether it's aortic or mitral? For that you have to remember a line. Draw a line from the left hilum. This is the hilum, right, where you have the vessels going down. So this is the left hilum. And what is this angle called? This angle is my CP angle, which is costophrenic angle. This is my other CP angle, which is my cardiophrenic angle. This is between the chest wall and diaphragm. Costo. This is cardiophrenic. So you draw a line from the right costophrenic to the left hilum. A for above. If it is above the line, it is aortic. If it is below the line, it is mitral. So that's how you will figure out which valve if they ask you that question. Clear? So this is about pacemaker and valves. What is the modality shown here? You can see the bones are white. This is a CT scan. A lot of students get confused with contrast study. They think that, oh, kidney has contrast, must be contrast study. But now you know better. What have we learnt about contrast study? It is when you are going to give contrast and then take an X-ray. So that is what is a contrast study. The moment you see that the bone is white, it's a CT scan. All right. Then what are you seeing here? 35-year-old. Which investigation will be detrimental? He is working with hammer and chisel and a foreign body enters the eye. So anytime you have a foreign body, we know MRI is contraindicated. CT is the investigation of choice. Which of the following MRI is better than CT? Already done it. Pancreas tumors, because I want to see nerves. Everything else in the lung is always a CCT or an HRCT. What is this modality? So here what you are seeing is the bone is white. So this is a CT scan. Even if I don't know what barium is, MR is, X-rays, I will talk about barium as we go along. But as you see the bone is white, you're seeing the intestines. This is CT enterography. Fine. This is what we do as the investigation of choice for small bowel. Remember, this is my best investigation for small intestine because I am going to give this patient mannitol. We give this patient oral mannitol to drink, which is osmotic agent, will distend the bowel loops. And if there is any stricture, like in this case, we will see the narrowing. So for any small intestinal pathology, CT enterography is the investigation of choice. We'll be learning barium soon in the next 5 minutes. But then that's not something which is done in practice. It's more or less theoretical now. Now for any bowel pathology, the best is a CT enterography. They are asking us, what is the investigation? Such a silly question. We know that, man, this is Doppler, this is triphasic, this is normal extremity, and they are asking us, what is it? It's Doppler ultrasound. 25-year-old male patient presented with a pulsatile supraclavicular neck mass. What is the most appropriate next investigation? Anytime you have a pulsatile mass, the next thing you will always do is a Doppler ultrasound. Because what does a pulsatile mass represent? Either it's an aneurysm or maybe you have a lesion which is sitting on top of a vessel. Either ways, I want to do a Doppler ultrasound to figure out if it's vascular or not. So the first thing is always any pulsatile lesion, do a Doppler. Don't stick a needle into it. Never ever you will biopsy a pulsatile lesion. Your patient will bleed to death the moment you give a needle biopsy here. You don't want to do that. CT angio may be done later on, but they are asking us the next investigation. Whenever they write best next, most appropriate next, it's the next investigation. Just think like a doctor. Don't get confused that, oh, should I go for best? Should I go for next? No, think like a doctor. What will you do next for this patient, right? Just keep it simple. I've seen so many students just getting confused for no reason in these investigation-based questions. Just keep it simple. If you are the doctor on duty, what will you just do next? Now, whether it is best next, most appropriate next, obviously you will do the most appropriate investigation, right? Why would you not want to do an appropriate next investigation? So keep it simple. It's Doppler ultrasound. Smoker male with painful ulcer. So there's gangrene. Any vasculitis in this person, when you have a smoker, what is your consideration? You want to rule out Berger's disease, right? Thromboangiitis obliterans. They are asking what is the best initial investigation. What is the best initial investigation for anything vascular? It is Doppler ultrasound. So remember, initial is ultrasound. Then they ask you best, CT angio, gold standard, DSA. Right? So this becomes Doppler ultrasound. With this, we finished the first part, that is general radiology. Next, we move on to GI. So let's begin the discussion now of GI and hepatobiliary systems. The first thing that I want to talk about are the barium studies. So as we discussed, barium sulfate is the compound that we use here, and we are only going to give it either by oral route or as an enema. We will never give it as an IV contrast agent. Okay, so that's something which is very important, and they need to be within the GI tract. If it leaks out, they have their own risk of peritonitis, so we will never ever give it in a suspected case of perforation or intestinal obstruction. So now, how do we name the studies? The studies are named according to the part that you're going to be testing. If we are testing the esophagus, the study is called as barium swallow. So the barium swallow study is where you're going to evaluate the esophagus, okay? So this is where the patient just drinks the barium and you take an X-ray to see the esophagus. If I want to evaluate the stomach, this is called as barium meal. So you can see here that the barium is within the stomach, and also the proximal duodenum can be evaluated here. So barium meal is for stomach and proximal duodenum. Now for the entire small intestine, what we do is barium meal follow through, what is referred to as BMFT. Barium meal follow through, where again the patient is going to drink the barium and now you're going to follow it for a while and see the small intestine. So barium meal follow through is for the small bowel. Now here you need to understand something. Look at this image. We need to know the parts of the small intestine. So what you can identify as a C loop is the duodenum. Now look at these loops here. you can see that they have a feathery contour, isn't it? So these loops are your jejunal loops. So the jejunal loops, remember, have this feathery outline. Why is this so? So this feathery outline of the jejunum is because of these folds. So now these jejunum, anatomically we know, have these folds which stretch across the lumen. These complete mucosal folds are what we call as valvulae coniventis. So remember, this valvulae coniventis is what is the hallmark of jejunum. Remember this, will also help us in intestinal obstruction. On the barium, it gives rise to this feathery contour, whereas our ilial loops, which are in the pelvis, more or less down in the pelvis, are going to be featureless. Imagine somebody's feature being that they are featureless. So that sad life is that of ilium. Okay, it has no loop, it has no folds. So that is what is the feature of ilium, right? So we have jejunum and we have ilium. Now, this is where the patient had taken the barium orally and we followed it into the small intestine. Compare that with this particular evaluation. My first question to you is, what do you think are these loops? So using the same concept, now you're going to see that, oh, now I see these folds so nicely. These are valvulae coniventis, isn't it? So this is what indeed are all of my jejunal loops. But aren't we seeing the distension much better than what we were seeing in our BMFT? We are. And the reason is I have put in a tube. So now I have put in a tube up to the DJ flexure, duodenal jejunal flexure, and now I'm injecting barium directly. Rather than having a patient drink barium slowly, I'm injecting the barium, which results in better distension. So this is what is called as barium enteroclysis. So this study is called as barium enteroclysis, where I am now taking a tube. We are taking a tube up to the DJ flexure and you are injecting the barium. So the distension is better. Understood how to identify? Look for a tube. If there is a tube, it's enteroclysis. If there is no tube, you can see contrast within the stomach also, means patient has drunk the barium. This is BMFT. Both of these are used for the evaluation of small bowel. As we discussed, even though we have these two studies, we don't do them in practice. In practice, we rely on CT enterography because that gives us a 3D perspective, right? So that is what we do in practice, but these are important for the exams. And look at the final image here. This is where you can see these incomplete folds called haustrations. So this study here is barium enema. Barium enema shows you this large bowel. The feature of large bowel are these incomplete folds that we call as haustrae. So these are the haustrae that are incomplete folds. So these are the various barium studies and their names. Now let's start from the esophagus and understand the different GI pathologies. So here I'm showing you two abnormal barium swallows. In the first one, you can see that the esophagus is completely distended with this smooth tapering distally. What is the diagnosis? This is the most commonly asked question. Don't get this wrong. This is achalasia. Achalasia cardia, as some people like to call it. So achalasia is essentially a motility disorder. It is a motility disorder wherein the lower esophageal sphincter does not relax. The lower esophageal sphincter is very tightly wound because there is deficiency of the inhibitory neurotransmitters. The inhibitory neurotransmitters VIP and NO are not there. So the lower esophageal sphincter does not relax, and because of that there's a functional stricture which develops, resulting in this dilated mega esophagus. So that's the pathophysiology there. Now let's further talk about how will you investigate it further. So the investigation of choice for this, because it's a motility disorder, remember, is a manometry. We do a high resolution manometry which will tell us that there is this increased lower esophageal sphincter pressure. It will also tell us that there is no peristalsis, because again, understand, for any peristaltic wave to proceed, You need something to constrict, which is acetylcholine, and you need something to relax. That's how a wave will go forward. If I don't relax, I will have no peristalsis. So that's what we see in achalasia manometry, that there is no peristalsis because there is no relaxation here. Clear? So this is achalasia. Radiology wise, you are going to see a smooth tapering. And what do we call this sign? This sign is called as the bird beak sign. So the smooth tapering bird beak is achalasia. Compare it with this particular patient here. Here you can see that there is this irregular sort of a narrowing. There are few outpouchings like diverticulae. Whenever you see such an irregular appearance, this is what is carcinoma. This is CA esophagus, and this irregular appearance is what we call as the rat tail sign. So CA esophagus, irregular, rat tail sign, and here the investigation of choice is going to be to do an upper GI endoscopy and take a biopsy to confirm. So this is where the investigation of choice is biopsy. Now, history-wise, please don't rely on weight loss. I've seen students do this mistake. They'll give you a patient who has history of dysphagia, who has weight loss, and then they give you this appearance. Most of the times in the exam, they give you achalasia. I've seen many students mistake it for CA and mark it otherwise. Very rarely have I seen a question on CA and students marking it as anything. So what you have to remember is achalasia has the highest chance of getting asked. Okay, so if you don't know, mark achalasia. Why will you not rely on weight loss? Because both of them can't eat. Now, if you can't eat, you're going to have weight loss. So both of these are going to have weight loss. Don't rely on that to mark your answer as carcinoma. Is that clear? So this is achalasia versus carcinoma. Looking at 3 more barium swallows now, look at this one. Can you see this linear sort of an appearance? This has been called as a pseudotrachea appearance because of the lines. This has been called as a feline esophagus because apparently cats have an esophagus like this. The diagnosis is eosinophilic esophagitis. So eosinophilic esophagitis on biopsy, you're going to see eosinophils in esophagus. So this is what is feline esophagus. Next barium swallow, if I tell you this is a patient who has history of HIV/AIDS. Now tell me your diagnosis. So when you see this diffuse involvement, there are these multiple ulcerations resulting in this diffusely irregular sort of an esophagus. This has been described as a shaggy esophagus. So in a patient with HIV/AIDS, shaggy esophagus, this is Candida. Candida esophagitis, remember, is an AIDS defining illness. Okay, so Candida is an AIDS defining illness. Candida oral thrush, not AIDS defining, but Candida esophagitis is an AIDS defining illness. All right, so that's what we need to remember here. Look at the next image. We can see that there is this corkscrew-like appearance of the esophagus, multiple spasmodic contractions. So this is where you have the presence of tertiary peristaltic waves. So here you are having diffuse esophageal spasm. So this is DES or diffuse esophageal spasm, and this appearance is called as corkscrew esophagus. Okay, so remember DES, diffuse esophageal spasm. Moving on to the next pathology. So now I'm going to discuss a bunch of pediatric emergencies for you, all of which very, very important. So this is our first patient. Tell me if you know the diagnosis, tell it in your mind. So what is the diagnosis? I think you have it. It is intussusception. So now let's do the related questions of intussusception. What is intussusception? First of all, it is the telescoping of one bowel into the other. Yeah, so that's what is intussusception. The age at which most commonly the patients will present is around 6 to 8 months, because this is the time when you start weaning off a baby of breast milk. You're going to start top feeds. This is also the time around which babies will get the rotavirus vaccine. So this is also one of the adverse effects which may follow rotavirus vaccination. That's a very, very important buzzword for you. Okay, so this is the time when a child is going to present. The child is going to be in a lot of pain. Now a 6-month-old can't tell you that I'm having pain abdomen. So they're just going to cry a lot, right? So incessant crying, and the mother might tell you that my child has blood-laden stool, also called as red currant jelly stools, right? So they might tell you that there is blood in the stool as red currant jelly stool. Now, 2 buzzwords for you whenever you hear this word red currant jelly stool. If it is painless, then you are going to consider Meckel's diverticulum. But if the child is in a lot of pain, crying incessantly, then you are going to think of intussusception, right? So these are my 2 DDs for red currant jelly stool. Coming back to intussusception, the most common type is ileocolic. And the significance of weaning comes in here. Whenever you are weaning of a child, or when you are giving these rotavirus vaccines, what happens is at the ileum you have Peyer's patches, right? Your mucosal collections. So these mucosal lymphoid collections are going to hypertrophy. So these Peyer patches hypertrophy, and that is going to act as a lead point leading the ileum into the colon. So ileocolic intussusception is most common. Now, when such a patient presents to you with such a history, the first thing you will do is an ultrasound. So shown here is the ultrasound. What can you observe? You can see that there is one loop of bowel and then there is other. So this is what is intussusception, referred to as various signs. People call it the target sign, donut sign. Some people call it sandwich sign. It looks like a kidney. On kidney also we see outer cortex is hypoechoic, medulla is hyperechoic. So this has also been called as the pseudo kidney sign. So 4 signs basically telling you that I can see 2 loops of bowels, one within the other, right? So we did the ultrasound and you saw this. What do you think is the best investigation? The overall best investigation, and I'm going on to calling it the gold standard, means that it is diagnostic as well as therapeutic. And what is that? That is barium enema. So in barium enema, what you're going to do is you're going to push the barium from the perrectal route. Now, suppose there is an intussusception at this site. Wherever the bowel loop has gone inside, this part here is going to present to you like a claw. So this is what we call as the claw sign. Okay. Now, why am I doing this barium? We said that barium is contraindicated in any obstruction. There's also an obstruction. But then I am not going from the proximal route. I am coming from the other side. I am coming from the perrectal route. So I am giving barium now to push the intussusception out. Whatever has come in, I want to push it out from here. So this is where now the bowel loop is going to go out like this. And this pattern is what is called as the coiled spring appearance. So when the intussusception reduces and it comes out, this is what we call as the coiled spring appearance. Is this clear? So claw sign, coiled spring appearance on barium enema. Now, instead of barium enema, if they give you air enema, saline enema, we can even do those, right? So saline enema is usually given with ultrasound, whereas barium and air are given along with X-ray, right? So that's what is the concept here. Any enema will do the trick. We just need to create the hydrostatic pressure to push it out. Okay, so that's intussusception. Next, pediatric emergency. This is where you have a neonate who's presenting to you with respiratory distress. So the clinical feature here is neonatal respiratory distress. See the X-ray and tell me what is wrong. we can see here that all of the bowel loops have come inside the thorax. So this is happening on which side? This is the left side. This is happening because the diaphragm here is not well formed. So there is herniation of the bowel loops into the thorax. So the diagnosis is congenital diaphragmatic hernia. Okay, so this is what we call as CDH or congenital diaphragmatic hernia. There are two types to this. You want to remember a word BPL, below poverty line, BPL. So there are two types. The more common type is the Bokdelek hernia. Bokdelek hernia is a posterior defect on the left side. So this is what is our Bokdelek hernia because it's on the left side. The other type is called as the Morgagni type. Morgagni hernia is seen on the right side and it's an anterior defect. So if you just remember BPL, everything is sorted. So this is where you have a defect on the left side through which the bowel loops are herniating, whereas in Morgagni, just the liver, because liver is anterior on the right side, just the liver herniates a bit upwards, and this is what presents late in adults, right, as mild discomfort. Whereas Bokdelek is the one which is going to present to you as this neonatal respiratory distress. Okay, so that's what is the one type we are discussing right now. Now, look at this X-ray and understand what's going to happen. My heart was supposed to be on the left side. Because the bowel loops came up, the baby's heart got displaced to the right side. So now the left lung is gone because of the bowel loops and the right lung is being pushed because of the heart. So that is why this baby has pulmonary hypoplasia, and that is the most important prognostic factor. So what I need to do is ensure that the lungs can be inflated as much as possible. So for that, what do you do first? If they ask you what is the next step, what will you do? First, I need to ensure that the child gets some oxygen. The child is in respiratory distress. So the first thing you do is put an ET tube. Next thing you do is you put an NG tube. Very, very important, because NG tube, when you'll put, you will decompress the bowel loops. You'll cause some space for the lung to increase. So that is what you have to do, and eventually the patient will have to be taken for definitive surgical repair. Very, very important question that is repeatedly asked is what will you not do? So what you will not do in this patient is bag and mask ventilation. When we do bag and mask ventilation, I just blow air in the mouth. What happens is the air not just goes into the trachea, it's also going into the esophagus. So now my bowel loops further inflate, which I can't have here. So that is why we will never do bag and mask ventilation. Look at the X-ray again. Can you appreciate that there is one ET tube? This one here is an NG tube. So NG tube not just decompresses, it also confirms your diagnosis. Normally NG tube should go here into the stomach, but here you can see that the NG tube is pointing into the thorax, hence confirming that the stomach has herniated into the thorax. So both of these can be done. Then you are seeing your bowel loops and the heart being displaced. So this is our all questions that are covered from CDH, congenital diaphragmatic hernia. I want you to contrast that with this particular image. Can you see one air fluid level here, and there is no air fluid level in the left diaphragm, below the left diaphragm? That is where I expect stomach's air fluid level to be. So what does this mean? It means that the stomach has now herniated into the thorax. When it does so in the midline, what is this called? This is what we call as hiatal hernia. So this is hiatal hernia, where through the hiatus, the esophagus brings the stomach up into the thorax. Fine. So hiatal hernia, as you know, are two types. The more commoner is the sliding hernia, where the G junction slides up. The other one, which is less common, is the rolling hernia, where the J junction is in place. It's normally the fundus which comes up. Which type do you think this one is? If it's just the junction, will I have an air fluid level? I won't. I will only have the air fluid level if the fundus is up and the G junction is in place. So this hernia in the image is actually our rolling hernia, all right, because I can see the fundus up into the thorax. So they will ask you this image and they won't ask you type, but they'll ask you what is the diagnosis, and this is hiatal hernia. All right, so remember when you see a retrocardiac, this we describe this as a retrocardiac air fluid level. Behind the heart, we have an air fluid level. Okay, so this is hiatal hernia. Next, we are discussing 3 emergencies. Let me give you the clinical picture first. Here, the child has presented to you with projectile non-bilious vomiting, whereas the other 2 cases, the child is presenting to you with bilious vomiting. So that's the clinical history. In the first one, when they say projectile non-bilious vomiting, the first thing that comes to our mind is CHPS. Non-bilious means it's proximal to D2. Yeah. So this is at the level of the pylorus. What is CHPS? Congenital hypertrophic pyloric stenosis. This is where the pylorus muscle is so much thickened that it leads to gastric outlet obstruction. Okay, so this is where a child is going to come to you as soon as the baby feeds. They're going to have non-bilious vomiting. For CHPS, you want to remember investigation of choice is ultrasound. Ultrasound will demonstrate the thickened pyloric muscle and the increased length. If you want to remember the numbers, the length must be more than 16 millimeters and the diameter must be more than 4 millimeters. So you can remember 4 fours are 16. So 4 and 16. If I do an X-ray here, you're going to get one dilated loop of stomach here. So this is what is called as a single bubble sign, because the stomach is filled with air and then I have obstruction, so the air can't go distally. On the other hand, what do you see? Here now we can see 2 bubbles. One bubble is the stomach here, which is distended, and the other bubble is the duodenum, which is distended. So this is what we call as the double bubble sign. And where do we see this? This is what you're going to see in duodenal atresia, where most commonly the second part of duodenum is atretic, and that's why the proximal duodenum and stomach become dilated. DO, DO, DO. This is also related to Down's syndrome. Look at the third one, recent FMG question. You can see 1, 2 and 3 bubbles now. So this means that the obstruction is even distal to the duodenum, meaning this is our triple bubble sign indicating jejunal atresia. So this is jejunal atresia. Done. So single bubble, CHPS, double bubble, duodenal atresia, triple bubble, jejunal atresia. Next, talking about this condition wherein you will be given a child who's presenting to you with bilious vomiting. Again, an infant with bilious vomiting, intestinal obstruction. You are doing an upper GI contrast study. Because the child is in obstruction, you won't do barium, but you can use a gastrographin or iohexol as contrast. So we have given this contrast orally. This is the esophagus, this is the stomach, and now what do you see? We see that the bowel is twisting upon its own axis. Can you appreciate this? So this is also referred to as corkscrew sign. Remember corkscrew of diffuse esophageal spasm? Which bacteria has corkscrew motility? Treponema. And now I have corkscrew sign here, and what does that indicate? It indicates that the midgut is twisting on its own axis. So the diagnosis here is midgut volvulus, and midgut volvulus is something that you will frequently see with malrotation. So this is midgut volvulus with malrotation. When you look at the CT scan, again look at these. These are vessels, mesenteric vessels. And can you see that twisting on their own axis? So this is what is also referred to as a whirlpool sign, the twisting of the mesenteric vessels. So this is midgut volvulus, malrotation. It's a surgical emergency. For malrotation, you would do a surgery that is called as the LAD procedure. Right? So that's what you need to know here. Very, very important, almost a certainty that in every exam you'll get a question on this. You will have a patient who is coming to you with intense pain, abdomen. They will give you buzzwords like the patient having guarding, rigidity, tenderness. So these will be the buzzwords that they give you. They will first ask you, what is the next investigation? So the next investigation or the first investigation that you're going to do is a chest x-ray PA erect view. So chest x-ray PA erect view is what you will do next. This is what it looks like. So this is what frequently they'll give in the exam. Where will you look? Will you look under the left diaphragm or the right diaphragm? We will look under the right diaphragm always, because as we discussed, this is stomach air, which is normal. So don't look under the left side, always look under the right diaphragm. And when you see that there is air, this indicates that there is free air. When I'm standing and there is free air in the abdomen, it will come up against the diaphragm. So this is what is the diagnosis of perforation peritonitis or pneumoperitoneum. Is this clear? The moment my X-ray shows me perforation or pneumoperitoneum, what are you going to do next? So if the chest X-ray PA erect view is positive, it shows you perforation, this is a surgical emergency. You're going to resuscitate the patient and take the patient up for exploratory laparotomy. So this is a surgical emergency. Take the patient up for surgery. You can resuscitate if given in the options. Now, few more pointers here. What if the patient is too sick to stand? Sometimes your patient may be too sick to stand, right? Can't even stand up for an erect view. Now, what can you do? Now, you can ask him to turn at least. Which side? You will ask him to turn to left lateral decubitus. Left lateral decubitus means left side is down and the right side is up. Will look something like this. So now when the right side is up, if there is free air, again I will see it against the liver. Getting it? If I had done a right lateral decubitus, I would have had stomach here. Now stomach also has air, outside also there is air, I would have missed it. But on the right side, there's only liver, so I can see this very nicely. So when the patient is too sick to stand, the view you will do is left lateral decubitus. But if they tell you that we are still suspecting a perforation, but the X-ray is normal, what is the most sensitive investigation? So the most sensitive investigation is a CECT, particularly with oral contrast. So we may give IV as well as oral iodinated contrast, because that not just shows the air, it will also show you the exact site of the leakage. All right, you'll see the white contrast spilling from the site of perforation. So that is what you can see here. You are seeing this black air, which is the free air. Now when the patient is supine, CT scan patient is supine, right? So the air is going to come anteriorly. So that's where you got to look at air on a CT. Got done. So this is about CCT, the most sensitive investigation. And what I am showing you here in a baby, can you figure out this belongs to a neonate? In a neonate, one condition is necrotizing enterocolitis. In necrotizing enterocolitis, the last stage, according to modified Bell's, we call it as 3B, is pneumoperitoneum or perforation. Now, can you ask a neonate to get up and do a chest X-ray PA view? He can't. Can you ask neonate to turn to left side and stay for a while? You can't. Now, in a neonate, the only X-ray I can take is a supine view. And in that, what I'm going to get is air completely surrounding all of the organs. And this is what is called as a football sign. So, another sign of pneumoperitoneum on a supine radiograph is what we call as the football sign. Clear? So this is all about pneumoperitoneum. Chest X-ray PA erect view, look for right air under the diaphragm. If too sick to stand, left lateral decubitus. CT is most sensitive. Football sign in neonate. So this is what we need to remember. here. So now let's talk about intestinal obstruction. So whenever you get a patient who has abdominal pain, obstipation means failure to pass fecal matter as well as flatus. So when you have complete obstipation, abdominal distension, vomiting, these are all features pointing towards intestinal obstruction. So this is the history that they'll give you, and then either they'll ask you what is the next step, or more commonly what they'll do is they'll give you one of these images and they'll ask you what is the diagnosis, and then they may ask you the management. Okay, so first of all of these patients of intestinal obstruction are going to undergo conservative management in the form of IV fluids. All of these are going to get an NG tube for decompression, and they are kept nil per oral. So this applies to everybody. Then what we do is we get X-rays done. Normally in practice, you will get supine plus erect abdominal X-ray done. If they ask you to choose in between the two, what you will choose is a supine X-ray. So remember the first thing, that the X-ray that you will prefer is supine more than erect X-ray. Both of these have their own applications. A supine X-ray is going to show you the distended bowel loops. Now, what do I call as a distended bowel loop? Normally also bowel loops are going to have air. So what is the difference between a bowel loop which is distended and something which is normally filled with air? It's the diameter. So let's first talk about this, and here you want to remember the rule of 3, 6, 9. A small bowel obstruction or a dilated small bowel loop is anything which is more than 3 centimeter. A large bowel obstruction, it is more than 6 centimeter. And a cecum is dilated when it is more than 9 centimeter. So this is small bowel, large bowel, and cecum that you want to remember. 3, 6, 9. It is this diameter beyond which I'm going to call a bowel as obstructed. So that is what supine view shows us. An erect view is going to show you this. Whenever somebody is standing, you know that air will rise up and the fluid is going to go down. So suppose this is a bowel loop which is obstructed, and the fluid basically layers out. So this is where you are going to have the air fluid levels. These horizontal levels that you can see here, so many of them, this is what we can only appreciate when somebody is standing. So that is what erect X-rays will show you in cases of obstruction, are these air fluid levels, and these levels we see in cases of small bowel obstruction. Okay, so this is what is the X-ray that you need to remember. So it's supine more than erect X-ray. So now let's jump into the X-ray. So this is the first X-ray that is shown to you. So as you can see these multiple air fluid levels, this is what we refer to as the step ladder sign, and this is what is suggestive of small bowel obstruction. These are not seen in large bowel obstruction. Next, whenever it is small bowel obstruction, the loops are going to be central. So SIR says small bowel, SIR says centrally oriented bowel loops. On the other hand, look at this X-ray now. You can see that this loop here is oriented towards the periphery. So a large bowel, because of its anatomy, right? So large bowel obstruction is going to be peripheral loops which are dilated. Small bowel is going to be central loops which are dilated. Then look at the characteristics. Can you see what we studied even in the barium studies? Can you see these complete mucosal folds here? So when we see these complete mucosal folds, that is what is called as valvulae conniventis, and you remember that this is a feature of jejunum. So this tells me that these are the jejunal loops which are dilated and it's small bowel obstruction. The ileal loops tend to be here in the pelvis. So in this case, you can see that it's jejunal loops which are obstructed and not the ileal loops, right? So this is how we can know what loop is actually dilated and where the probable level of obstruction would be. In this case, we can see it's somewhere between jejunum and ileum, right? On the other hand, here in the large bowel, can you all appreciate that there are these incomplete folds? You can also see that this loop is dilated till here and then it stops, meaning there must be a cause of obstruction somewhere at this point. So this is what we call as the transition zone. Plus, can you appreciate these incomplete folds here? So this is what we call as haustration, and you know that that is a feature of large bowel obstruction. So whenever you see haustration, it is large bowel. Whenever you see valvulae conniventis, it is small bowel. Yeah. Now let's talk about the theory questions here. The most common cause of small bowel obstruction is adhesion. So these adhesions form due to some sort of prior surgery. So they will give you history of a prior surgery, whereas large bowel obstruction, the most common cause here is cancer. The most common cancer of the GI tract is the rectum. So CA rectosigmoid junction, if asked to choose rectum more than sigmoid colon, right? So that is what you can also expect in this particular case, somewhere close to the sigmoid colon, you would be having most likely a mass. Small bowel obstruction, the management is usually conservative. So you will see, wait and watch, unless you have some high risk features, you will wait and watch for 24 hours. There is no point of operating, right? Because why was this caused? This was caused because of a prior surgery. Now, if you again do a surgery in every case, you are starting a vicious cycle wherein again the patient might develop small bowel obstruction. So don't want to keep doing that. So it's conservative. You wait. If there are some high risk features or the patient doesn't resolve in 24 hours, then you can go ahead and operate. But the initial management, which is expected of you to know, is conservative. On the other hand, large bowel obstruction, the cause is cancer. You can't tell the patient wait for 24 hours. If your cancer doesn't go away, then we'll operate. No, you can't do that. So this is where you have to operate straight up, right? So this is what is the approach to intestinal obstruction and the relevant points that we need to know about. Now, talking about volvulus. The meaning of volvulus is when one organ is going to twist on its own axis. That is the definition of volvulus. This can happen either in the sigmoid colon or the cecum. So now, what are the two main features to distinguish? There are a lot of differences which I've also discussed in the main video, but actually when you look at a radiograph, the two features which are really going to help you are, first, whether you see haustration or not. Look at the first X-ray. You can see that there are no folds whatsoever. So it is a ahaustral loop. So the first point is whether haustre is there or not. Second X-ray, where we are seeing the same thing here. Now you can appreciate that in this particular dilated bowel loop, we can also see the haustrations. So this is where the haustre are present. That's the first thing you observe. The second thing you have to observe is how many loops can you see. In this particular X-ray, you can see 1 and 2. 2 loops of bowel which are dilated, whereas in this, you can see one particular loop of bowel which is dilated. So the second point we observed is whether 2 loops or 1 loop. Now what we have to see? Few signs. So I think all of you can appreciate here, all of you very well know this is what we refer to as the coffee bean appearance, where it looks like, indeed looks like a coffee bean, also been referred to as a bent tube sign. So all in all, ahaustral, 2 loops, coffee bean, bent tube, all of these are findings of sigmoid volvulus. So this is sigmoid volvulus. You will be mentioned a few risk factors like an elderly patient who's had chronic constipation. How do we manage sigmoid volvulus? We are gonna put a flatus tube. So either they will write flatus tube insertion or they may write endoscopic detorsion. The point remains you don't need to operate this patient. You put in a tube or an endoscope and the sigmoid colon is deloaded or unloaded and you will be able to detort it. On the other hand, when you see a haustral single loop looks like a C. Yeah, so this is what has been called as the C sign, C for cecal volvulus. So this is cecal volvulus. Here you would be given a few risk factors like pregnancy. There might have been some pelvic surgery which has been performed here. How do you manage this? This patient needs to be operated. Okay, so this is what we need to remember as far as a holistic approach of sigmoid versus cecal volvulus is concerned. The other features like where it originates from, where the apex is not reliable, because when a bowel loop becomes distended to a certain limit, after that the position can change, right? So that's something which is not reliable. Cecal volvulus is considered to be a clockwise twisting, C for C, whereas sigmoid is anti-clockwise. Again, something not very reliable because you can't really observe that on the X-ray, right? That's more of a theoretical point. So in practice, if you observe these 2 points, you are sorted. Okay. So now let's talk about a few important barium signs. Look at the first image here. So this is where you can see, first of all, these are the jejunal loops. You can say that from the outline, the feathery outline that we are observing. These are the terminal ileal loops. And now you can see this is the place where the ileum is supposed to join the cecum. So this is our terminal ileal loop. At this point, you can see that there is a stricture, there is a narrowing. This has been called as the string sign because the ileum looks like a string. So this is the string sign. Now, just this ileal stricture can be seen in variety of conditions, the two most common causes being TB and Crohn's disease. TB can involve any part of the ileum, but the most common part you want to remember is the junction. The most common area is ileocecal junction. This is associated with pulled up cecum. In the chronic stages of TB, you're going to have fibrosis and contractures, and the cecum tends to get pulled up. So that is what we observe in TB, pulled up cecum, right? So that is what you need to know. In addition, the most reliable finding is not barium. We already discussed that barium is not something that we actually do in practice. In practice, you do a CT enterography. In a CT scan, when you see an ileocecal junction stricture, along with necrotic lymph nodes, it's these necrotic lymph nodes which are the hallmark of tuberculosis. Whereas Crohn's disease is where the terminal ileum is indeed the most common part. It tends to spare the ileocecal junction. It's the terminal ileum, and this sign in terms of Crohn's disease is what we refer to as string sign of Cantor. So when I say string sign of Cantor, it is C for Crohn's, K and K. That's what you want to remember. Crohn's disease, when we look at the CT, the lymph nodes are going to be non-necrotic. We're going to see non-necrotic lymph nodes. So that is how we actually distinguish on the basis of a CT scan. So this is what you need to know about string sign. Then when we look at this barium enema here, you can see that the complete colon is missing the hostrae, which was its hallmark. So when you see this colon appearance where it has lot the hostration, this is what is called as the lead pipe colon appearance, and this is the hallmark of ulcerative colitis. You know, ulcerative colitis starts from the rectum. The most common part is rectum, and then it spreads in a continuous fashion to involve the entire colon. So that's what you can see here. When you see this irregular sort of an appearance, this is what has been called as the apple core appearance, and this is what represents CA colon. On this particular barium enema, you can see how there are these outpouchings of contrast. These are diverticulae. True or false? These are false diverticulae. Remember, all diverticulae are false except Meckel's diverticulum. Meckel's is the only true congenital diverticulum you need to know about. Right. So this is what we call as sigmoid diverticulosis. This is what is going to present as a painless lower GI bleed. So this is diverticulosis, which is painless lower GI bleed. You do the barium, and this particular sign is what is called as sawtooth sign. This is asked in FMG exams a lot, okay? So this is the sawtooth sign. Now, a potential complication of diverticulosis is diverticulitis. One of these diverticulae can become inflamed. The complication is it can then rupture to cause peritonitis. It may form fistula with the bladder and adjacent organs. So diverticulitis is a problem. Now, how will I know it is diverticulitis? You'll have symptoms of itis. So what are the symptoms? You will have pain in the left lower quadrant. You may have fever. You may have leukocytosis. So you'll be getting these symptoms of inflammation. Now, what is very important is you will never ever perform barium in diverticulitis. Barium becomes contraindicated because then if these diverticulae rupture, they are going to lead to peritonitis further. We're never going to give barium in this particular patient. That's very important. So now what do I do? How do I make this diagnosis? So here the investigation of choice, remember, is going to be a CECT. So CECT is going to be the investigation of choice for diverticulitis. In surgery, you will also study the Hinchey classification, right, of diverticulitis. So this is about these important conditions. Going on to this particular mass lesion in the liver. What is your diagnosis? 3 images, 1 diagnosis. What do you think? This indeed is hydatid cyst. So hydatid cyst, remember, is caused by Echinococcus granulosus most commonly. Echinococcus, what is the primary host? The primary host is a dog. That's why this is called as a dog tapeworm. Who is the secondary host? That is a sheep. Humans become accidental or dead-end hosts. So frequently they'll give you history of dog being a pet in this particular history, right? So that is what is about hydatid cyst. Now the radiological appearance. Before we understand the radiological appearance, you just need to know how it evolves, right? So basically hydatid cyst has 3 layers. Okay, so that is the first layer. Then you have a second layer. And then we have a third layer. So now we have 3 layers here. The first layer is what we called as the endocyst. The layer in blue is the ectocyst. And the outermost layer is the pericyst. Okay. The pericyst is actually not a layer of hydatid. It is the connective tissue of the liver, right? Because liver is the most common organ, or any other organ. The connective tissue is what forms the pericyst. Endocyst is what is the reproductive layer. This endocyst is what is going to form the daughter cyst inside, and that is what is going to then degenerate. Ectocyst is nothing but a lamellar membrane. All right, so this is not going to reproduce or do anything. It is just the lamella around it. All right. So now how does the hydatid evolve? As soon as you have a hydatid cyst, first you are just going to see the 2 layers and then you have the pericyst. Now the endocyst will show us the daughter cyst, and that is where you see this kind of an appearance where within a cyst you have multiple daughter cysts, and this appearance is what we refer to as the honeycomb sign. Now once the reproduction is done, the function of endocyst is apparently finished. So now what is it going to do? It is going to die. It is going to degenerate. So now the endocyst degenerates and it floats within the cyst. So can you appreciate here that we can also see, can you see this? That this is the ectocyst, and you can also see one more layer which is the pericyst, and the endocyst is floating inside. So the innermost layer is floating inside, and this appearance is what is the very famous water lily sign, right? So now it has degenerated. This is what we refer to as the transitional stage. This was the active stage, right? So this is active, and then you have the transitional stage. Eventually, this is going to become hydatid dust or hydatid sand. It settles, and then eventually the final inactive stage is when it becomes completely calcified. We know from our thumb rules, whenever I want to see calcification, what is the best investigation? What is this? It is a CT scan. When we see the bone is white, it's a CT. Can you tell me whether this is NCCT or CCT? How will you say? You will look in front of the vessel. You will look at the vessel in front of the vertebra. So this here is the aorta, and you can see that the aorta has no contrast. So this is a non-contrast CT scan. So this is an NCCT. When you see this white colored lesion in the liver, which is on the right side, this is a calcified hydatid cyst. Yeah, so this is calcified hydatid cyst, and this is the end stage of this. All right, so this is an inactive hydatid. You don't need to treat it. This is the final end stage. So this is what you need to know about hydatid. These are the 3 stages, 3 appearances that they can ask you. Liver indeed is the most common site. The second most common site is the lung. One thing that I can tell you about lung, you also see in the lung a similar appearance which is called as the water lily sign, where the membranes will crumble down. The only difference in lung is it never calcifies. Like how in liver we saw the end stages being calcified, a lung hydatid does not calcify. It's just how it is. Okay. So that is what you need to remember in general about hydatid. Okay. Next, let's look at gallbladder. We already discussed that anything to do with gallbladder, the investigation of choice is ultrasound. Gallbladder means ultrasound. So I'm now going to show you 5 pathologies of the gallbladder. All of these are ultrasounds. You have to tell me what is the diagnosis. So look at the first one here. What is it? What did we study? This is the gallbladder. You can see there is a hyperechoic stone, and behind it you can see that there is this shadowing. So this is what we refer to as posterior acoustic shadowing, making our diagnosis very simple as gallstones. So for gallstones, remember, investigation of choice is ultrasound. They are not radiopaque stones. They are made up of cholesterol pigment. So what we are going to rely on is the shadowing on ultrasound. Okay. Now, just gallstones, remember, most of the times are going to be asymptomatic. You can either have some biliary colic, which is pain, or you may have inflammation of the gallbladder, which we refer to as acute cholecystitis. So, acute cholecystitis, remember, the patient is now going to come to you with, again, itis features. So, you'll have fever, right upper quadrant pain. I'm sure all of you know the Murphy's sign, where if you press on the 9th costal cartilage, the patient winces in pain. So all of these are the clinical features. Again, the investigation of choice remains ultrasound, wherein what you will observe is usually there's an associated stone. Most of the cholecystitis are calculous cholecystitis. So you can see there is a stone obstructing the neck of the gallbladder. You can see this shadowing here. In addition, in cholecystitis, what you see is the wall, right? So in cholecystitis, compare it with uncomplicated gallstone. This is the thin wall which you can't really see. Whereas here you can see that the wall has become thickened, and not just that, you can see there is some layer of fluid within it. So this is what is a thickened wall. The exact number you may not remember, it's fine, but it's more than 3 millimeter. So we are actually looking at wall thickening here. So that is the hallmark of acute cholecystitis. Another way to diagnose acute cholecystitis is HIDA scan. So you can also use HIDA. They say theoretically HIDA scan is actually most accurate. It has highest accuracy for picking up acute cholecystitis, but we don't do it in practice because HIDA scan uses technetium. Technetium means gamma rays. It means a lot of radiation. When I can easily pick it up on ultrasound, why do I need to do a HIDA scan for this? So it's theoretically most accurate, but not done in practice. So don't get confused. If you get both options, you're going to mark ultrasound. That's what you do in practice. Okay. So HIDA scan, actually, just to tell you the concept, is just like bilirubin. It is excreted from the liver into the biliary duct and the gallbladder, and then it comes into the intestine. So normally you will see all of these structures and the bubble. What happens in acute cholecystitis? That this gallbladder is so inflamed and so obstructed that there is no HIDA which can enter the gallbladder. So what you see in HIDA scan is actually non-visualization of the gallbladder. So when you don't see the gallbladder, it is something which is abnormal, and that is when you suspect acute cholecystitis, right? So this is about acute cholecystitis. Look at the next image. What do you think is the diagnosis? There is a hyperechoic lesion attached to the wall. Is this a stone? This is not a stone because there is no shadowing. So this is what is a gallbladder polyp. This is a GB polyp. There is no associated shadowing and it is non-dependent. It is hanging from the wall. The importance of a GB polyp is any polyp which is more than 1 centimeter, it must be operated because there may be underlying malignancy. So less than 1 centimeter polyp, nothing, reassure. More than 1 centimeter, prophylactic cholecystectomy is performed here. Okay, so that's what is important. Look at the next image. This is where you see these small comet tails here coming from the wall. So this is what is called as the comet tail sign. And this is seen in adenomyomatosis. Adenomyomatosis is a condition wherein within the wall of the gallbladder, you have these diverticulae or outpouchings which form, and they tend to have these small cholesterol crystals. So these cholesterol crystals give this sort of a streaking here, which is our comet tail. So that is adenomyomatosis. The counterpart of this pathologically is what you study as strawberry gallbladder. I'm sure you've studied that in path. So that's strawberry gallbladder, which is cholesterolosis. Right? So you want to remember both of these go hand in hand. The clinical radiological diagnosis is adenomyomatosis. The next image has been asked in a recent exam. So what you see here is the gallbladder folded upon itself. So this is a gallbladder which is folded upon itself. It looks like it's wearing a cap. So this appearance is called as a Phrygian cap. Nothing needs to be done. It's a normal anatomical variant, right? So these are your 5 spotters from gallbladder that we need to know about. Investigation of choice, ultrasound. So now we said that all stones, it's CT except gallstones. What about CBD stones? That's another exception. So now CBD stones, the difference comes in that ultrasound may not be very reliable. Your entire common bile duct, the distalmost part is going to open into the duodenum. We said that air is the enemy of ultrasound. So if the CBD opens into the duodenum, we are not going to be able to see the distal CBD in a lot of patients, right? Because the duodenum may be filled with air. In very thin patients, lean patients, you may be able to see, but in most cases, we can't see the distal CBD. So most of the times, these stones or distal CBD pathology will be missed on ultrasound. So then what is the best investigation? So now let's talk about the approach to obstructive jaundice or any cause like CBD stones, which is causing the obstructive jaundice. First off, they will tell you that there is a patient who has come to you with jaundice. There are pale stools. They'll give you lab parameters like direct bilirubin is raised. They'll give you markers of obstruction like ALP, GGT being raised. And then they'll ask you, what is the next step? So the first investigation that you will do remains ultrasound. It may not be the best, but it has no radiation. The first one that you will do is an ultrasound. Now, ultrasound may or may not show you the distal CBD, but what you will definitely see is the proximal CBD. So this is where you can see this appearance, where this is the portal vein. The biggest structure at the portal triad or the hilum is going to be the portal vein. Anterior to portal vein, what you see here is the dilated CBD. Normally, it is very narrow. You will not see this like a barrel. But here you can see these two almost parallel structures here. And this is what has been referred to as a double barrel sign. Sign doesn't matter. What matters is anterior to portal vein, we have a dilated structure. Usually what happens in the exam, they tell you all of this lab parameters and they tell you that the ultrasound showed a CBD which is dilated. So that is what ultrasound will show us. It shows us a dilated CBD. CBD is considered to be dilated if it is more than 6 millimeters. Okay. So ultrasound told us that there is obstruction. CBD is dilated. But what is the cause? How do I know? So then the next step or the best investigation is going to be MRCP. As the name suggests, it's an MRI sequence, magnetic resonance cholangiopancreaticography. Cholangio meaning CBD, pancreaticography meaning main pancreatic duct. So this is where we are gonna see the CBD, and can you appreciate this thin structure here? This is the main pancreatic duct, and both of them can be seen opening into the duodenum. So this is MRCP. A few points about this. We do not use any contrast media for MRCP. We use the intrinsic bile, which is a fluid. Do you remember World War II? We remember that water is white on T2. So what we use is a T2 weighted sequence. We make it very heavily T2 weighted such that only structures which are T2 hyperintense are visualized. Everything else is black. Do you understand? I made sure that only things with fluid should be white. Everything else will be black. So that's how we can appreciate that, okay, this is the bile, bilirubin or bile containing CBD, which is filled with fluid, hence white. So this is where we don't need contrast. We use a heavily T2 weighted image. That's the first advantage. The second advantage you all know is this has no radiation because it is MRI. This is non-invasive. So all of these are the advantages, and that is what makes MRCP the best investigation. Look at the CBD here. You can see these are the intrahepatic bile ducts, and this is the common bile duct here. And can you see one black colored stone here? So this is what is called as a signal void. Basically, there is a void of the signal. There is no bile there. It is replaced by a stone. So that's a CBD stone. So this is how you're going to pick up CBD stone. So the investigation of choice for a CBD stone is MRCP. What now? How do we manage a CBD stone? So remember the gold standard. What did we say about gold standard? That it is diagnostic as well as therapeutic. So the gold standard for a CBD stone is ERCP. What is ERCP? E for endoscopic. Yeah, can you see this endoscope here? So we see an endoscope. You take an endoscope into the duodenum, you cannulate the papilla and you enter the CBD, and I put contrast. So that is where this involves iodinated contrast, and then I take an X-ray, so there is involvement of radiation. So this is an invasive technique that uses contrast and radiation, and that is where I'm going to see this image here where you can see we have put contrast inside the CBD, and can you appreciate there are all of these filling defects. The stones we know are not radio opaque, they are radiolucent, and we can see that the contrast outlines them, and that is what we call as filling defects. So these are the filling defects. You can also see the endoscope here on the image that helps you recognize ERCP. So endoscopic retrograde, you're going from the other end, cholangiopancreaticography. You are inside, you can remove the stones now as well. So this becomes the treatment of CBD stone. Did you understand? So in cases of obstructive jaundice, you have to remember it's ultrasound followed by MRCP followed by ERCP. The only potential confuser that they can give you here is, what if ultrasound only shows me that there is a distal CBD stone? In that case, now do I need MRCP? Then I don't need MRCP. If ultrasound could show you CBD stones, then go straight away for ERCP. But if they mention that ultrasound is showing me gallstones with dilated CBD, then what do you think should be the next step? Gallstones is independent. How do I know what's happening with CBD? So unless and until they mention CBD stone, remember you have to do MRCP to see the CBD stone. Are you understanding? So ultrasound followed by MRCP followed by ERCP. That is the protocol for obstructive jaundice. Then we have this image here. What do you see? This is an MRCP image. We can see that there is this irregular dilatation and narrowing. So you can see there are these dilated saccules followed by this narrowing. So this is what is called as a beaded appearance. Normally, both of the sides of the intrahepatic ducts are involved. The diagnosis is PSC. What is PSC? It is primary sclerosing cholangitis This is a pathology that is associated with IBD, inflammatory bowel disease. Within it, it's UC more than CD, ulcerative colitis more than Crohn's disease. And what you have to remember is this is a pre-malignant condition. This has a very high risk of developing cholangiocarcinoma, right? So beaded appearance, PSC, primary sclerosing cholangitis, they will confuse you with PBC, primary biliary cirrhosis. Remember, that does not show you this beaded appearance. In that case, the MRCP is more or less normal. In advanced cases, you will see distal peripheral bile ducts being narrowed. Okay, so that's a late finding. You don't really need to know about it, but this image has been asked a lot of times. So here what we see is a spotter again. What can you see on this X-ray? You can see that along the pancreatic duct, there are these various calcifications. Can you see these white things on an X-ray? We know is calcium. So when you see calcifications along the pancreas and the pancreatic duct, this is what is a diagnosis of chronic calcific pancreatitis. When you see pancreas having calcification, that is chronic calcific pancreatitis. The investigation of choice for chronic calcific pancreatitis is ERCP. On ERCP, we again cannulate the pancreatic duct, and can you see this is the main pancreatic duct which is opened up, and you can see these various side chains which have opened up. So when you see these side chains, this is what has been described as the chain of Lake's appearance. As the severity increases, you will see this becoming more and more dilated. The main duct becomes more dilated, the side branch becomes more dilated. So that is what you see in chronic pancreatitis. Now let's look at the questions here. So we have a 6-month-old baby with bilious vomiting. We already discussed this. You can see these 2 bubbles here. So what is it? Double bubble sign, duodenal atresia. If you see 3 bubbles, it's triple bubble. If you see a single bubble, then it is CHPS. Midgut volvulus we had seen was the corkscrew appearance. Radiological investigation of choice for pheochromocytoma. So this word is very important. Remember, we have studied this in BTR as well, that investigation of choice for anything endocrine is usually going to be a biochemical test. It's not going to be radiology. Radiology mainly helps in localization, not the diagnosis per se. Same applies to pheo. For localization, the best investigation is MRI, right? So MRI is the radiological investigation of choice, not ultrasound or CT or FDG PET. For pheo, what we do is a DOPA PET. DOPA PET helps in cases of pheo, but still if asked to choose, you will go for MRI. Okay, so that is what you need to know here. Overall, the investigations which are done are going to be plasma metanephrines or urine metanephrines, okay? So radiological investigation of choice is important. What you see in this case, you can see CBD folded upon itself. This is nothing but the Phrygian cap. What is Mercedes-Benz sign? So this is something that you see in gallstones, okay? We said that gallstones are radiolucent. We won't pick them up on X-ray or CT. But when you see them on X-ray CT, they tend to show this trapped air inside the lucent stones. So we know air is going to be black, right? So you see this black colored air shadow within the stones, and that is what is called as Mercedes-Benz sign. So gallstones on CT or X-ray may give you this sign. Not very, very important. Polyp and cancer, you already know. What is this? So you can see the same image we had seen. We are seeing a signal void. This is CBD stone or choledocholithiasis. What is this? You can see that there is a calcified lesion in the liver. This is our hydatid cyst. Hepatocellular carcinoma or FNH. Remember, for liver masses, what we tend to do is a TPCT, a triple phase CT scan of the liver. At your level, what you need to remember is we take an arterial phase and a venous phase. We give contrast, and then I take a phase where the contrast is in the arteries, and then I take a phase a bit later when the contrast is in the veins. HCCs have a property that they don't get blood from portal vein, but they take blood from hepatic artery. So in the arterial phase, this is going to show us enhancement, Vessels are there in a tumor. There is neoangiogenesis. So there is very rapid washout. So what you want to remember is when you see a liver mass with arterial enhancement, venous washout, we are describing an HCC, right? So that's what you need to know. FNH is a lesion with a central scar. We will talk more about it in nuclear medicine. As of now, you want to remember a central scar is FNH. Fine. So this is about the liver masses. This was asked in FMG. So now looking at these signs, so this is a recent FMG question here. So football sign is something that we saw an image with pneumoperitoneum. So one is D. So this leaves us with two options. Rat tail sign, you remember, was CA esophagus, whereas bird beak was smooth tapering with achalasia. So B is 2. So we already have our answer. Just to confirm, 3 is A. Yes, string sign in CHPS. So string sign we also saw with Crohn's and TB. But even in CHPS, when you do a barium meal, what you see is that the pylorus, suppose this is the stomach filled with barium, the pylorus is thinned out, and that is what is going to appear as a string. So that is correct. And inverted umbrella sign is the pulled up cecum. So when in TB, you have the IC junction involvement, you are going to have the cecum and the ileum getting narrowed, and that is what looks like an inverted umbrella. It's also been called as gooseneck sign, Sterling sign. There are many signs that you just need to, hear once. So this is about the signs. Next, abdominal pain, distension, chronic constipation. Look at the image. 2 tubes, coffee bean, A hostile. This indeed is sigmoid volvulus. The history also favors the diagnosis. Next, 48-year-old female presenting with right upper quadrant pain. Ultrasound shows us multiple GB calculi but no wall thickening. So from this I know that there are gallstones. There is no cholecystitis per se. CBD diameter 12 mm. That tells me that the CBD is indeed obstructed. We said anything more than 6 mm is dilated CBD. GGT is raised, ALP is raised, meaning there is obstruction, but they do not tell me whether there is distal CBD stone or not. So what do I have to do next? Right? That is MRCP. So MRCP to confirm. So what did I tell you? Don't be like gallstones means there are CBD stones. No, we got to see what is the cause of distal CBD obstruction. So that is where we need to do MRCP. Once MRCP confirms, then we will go for ERCP. Next, 40-year-old female comes with jaundice, pain abdomen, LFT reveals raised bilirubin and GG. So you can see there are many variations of a similar topic that has been repeated a lot of times. Every time they change one thing and the answer changes. So you got to be very thorough with this topic. Okay. So what we see here is that the ultrasound shows me a scleroatrophic gallbladder. This is just a fancy way of saying that GB is contracted, and that is what we see in a patient with chronic cholecystitis. Again, now they tell me there is dilated CBD, but they also mention there are impacted calculi. So now that there are calculi, now what do you want to do? Now, is there a role of MRCP if ultrasound has already told me about the stones? Not really. So that is why MRCP is not the answer and it is ERCP straight up, because ultrasound could show me the CBD stones. Are you understanding this? Let's look at one more question. 56-year-old male with obstructive jaundice shows a dilated CBD and intrahepatic bile radicals. So I can see dilatation, but no stone could be identified. CT also showed me similar findings. So now what do we need to do? Now I need to do MRCP. When this actual question came, a lot of students were like, ma'am, MRCP option mein nahi tha. It was not there in the option, so we ended up marking ERCP. But what is MRI? MRI is MRCP, right? So MRCP is what is the sequence of MRI. So when MRI is in the option, you mark that. Okay, so don't be fixated that, oh, MRCP is not there, let me go to ERCP. Just be with an open mind and look at the options and you'll reach the answer. Next, 60-year-old female with increased bowel sounds. We are seeing dilated small bowel loops and air in the biliary tree. This is a buzzword. Whenever you hear pneumobilia, it can be one thing only, which is gallstone ileus. Gallstone ileus is where you have a communication of the gallbladder with the duodenum. Because of that, a stone passes into the intestine, leading to small bowel obstruction. So that is where you will have air in the biliary tree, you will have small bowel obstruction, and you will have a gallstone. So when you see this triad of pneumobilia, small bowel obstruction, and gallstone, this triad is called as the Wriggler's triad. Remember, pneumobilia, gallstone ileus. Portal venous gas, think necrotizing enterocolitis. So both of these are buzzwords. Portal venous gas, think of NEC. We remember stage 2B. We have studied that in Pete's BTR. But what is gallstone ileus? Pneumobilia, bile duct having air. Understood? Don't be fixated on this history of hysterectomy. So a lot of students ended up marking small bowel obstruction because of adhesions. They thought it's adhesions, but no. Air in the biliary tree can't be seen in any adhesive obstruction, right? It will only be seen in gallstone ileus. 35-year-old male, severe pain abdomen, has a radius fracture for which he's taking a lot of painkillers. How is that relevant? NSAIDs, you know, can lead to peptic ulcers. Peptic ulcers can perforate, leading to pneumoperitoneum. So where do we look? We look under left diaphragm or right diaphragm? Right diaphragm always. So under the right diaphragm, when you see that there is air, what is it? It is perforation peritonitis or pneumoperitoneum. What do you want to do next? Look at the options. Advise him to stop painkillers. You're like, okay, right now you might die, but don't take painkillers later. Does it make sense? E-FAST is an investigation we only do in trauma. Extended focused assessment sonography using trauma. We study this in surgery. No role here. Barium, we said, is contraindicated in any case of perforation. So barium can never be done. So the next step is exploratory laparotomy. It's a surgical emergency. You're going to go ahead and do an exploratory laparotomy. Okay. If IV fluids is mentioned, mark that as your appropriate next step. If it's not there, go for exploratory laparotomy. 8-month-old child after vaccination presents to the emergency with crying, meaning there is pain. Vaccination. Which vaccine? Rotavirus vaccine most likely. X-ray abdomen is normal, no signs of free air. Ultrasound is done. What do we see? You see a target appearance. You can see a bowel within bowel appearance, which indicates intussusception. What do we do? What is the investigation of choice? It is air enema. Any enema, barium enema, saline enema, air enema. Basically, we want to create hydrostatic pressure so that we can reduce the intussusception, right? So the answer here is B. What is the least? Read the question very carefully. Lots of students just jump to the diagnosis, mark manometry and come back. Then they later realize, oh, they are least useful. So what is the least useful? What are you seeing? First of all, you can see a smooth tapering here. This is achalasia cardia. Here, barium swallow does have a use. Upper GI endoscopy can be done to distinguish it from cancer. Manometry is the investigation of choice, but 24-hour pH monitoring has no role. That is what we do for cases of GERD. It has no role in achalasia or carcinoma esophagus. So the least useful is 24-hour pH monitoring. If they ask you the most useful, we go for manometry. Right? So this is what we had from GI. The last question here, 45-year-old male presents with colicky pain abdomen with vomiting. They are showing us an X-ray. What is the diagnosis? So here the options are a bit tricky. It's not just small bowel, it's proximal versus distal versus large bowel, and there's nothing called a pseudo small bowel, so you can rule that out. So what you see here, first of all, in the X-ray are these loops which are essentially dilated. Can you tell me what are these loops? Jejunum, ileum, colon. You are right. We can see that there are loops which have folds throughout the lumen. Complete folds within the lumen are valvulae conniventus, and you know valvulae conniventus are a feature of jejunum. So these are the jejunal loops which are dilated. What about ileum? Is ileum dilated? Not really. We can see that within the pelvis, there is no dilatation of any bowel. So this indicates that there is an obstruction somewhere between jejunum and ileum, indicating proximal small bowel obstruction. If this was distal small bowel obstruction, I would have had jejunum plus ileum dilatation. Getting it? So this is what is proximal small bowel obstruction. So with this, we complete the section of GI radiology. Next, we move on with the next system, that is genitourinary and women's radiology. So the first thing that we need to study in genitourinary radiology is going to be the signs on IVP. First of all, what is IVP? IVP stands for intravenous pyelography. This is where we're going to inject the contrast just as we do for any other investigation into the venous system. So you put a venous cannula, peripheral venous cannula, and you're going to inject the contrast. What did we study? We studied that the contrast is injected from the renal system. So around 10 to 15 minutes after the injection, the contrast is supposed to be excreted out from the kidneys. So at that time, if I take an abdominal X-ray, this is the kind of image I'll see. I'll see the collecting system of the kidney. Can you appreciate? These are the calyces, this is the pelvis, this is the ureter, which is entering into the bladder. So we just have to take an abdominal X-ray after injecting contrast around 10 to 15 minutes later, and that investigation is IVP, intravenous pyelography. Understood? So this is where we have to see some images and diagnosis. What are you seeing here? In this, we can see that the distal end of the ureter has this cystic sort of a dilatation. What is this called? This is what is called as adder head. Looks like a snake's head, yeah, which is more bulbous than the rest of the body. So this is what has been called as the snake head, cobra head, adder head, whatever you prefer. What is the diagnosis? The diagnosis is ureterocele. Ureterocele means a cystic dilatation of the distal end of the ureter. So this is a ureterocele. Look at the next image now. So normally when we look at the calyces, the kidney are facing on the two sides and then you have the ureter. But in this image, what you can appreciate is now the inferior poles are rotated and facing medially. So this is what is horseshoe kidney. So horseshoe kidney is where the inferior poles of the two kidneys are fused and meeting in the midline. So the IVP looks as if the inferior pole are trying to shake hands, right? So this is what we refer to as shaking hand calyces. Some people have also called it the flower vase appearance or the flower vase sign. So this is the IVP appearance. What has been very commonly asked these days is the CT appearance. So first let's look at the image. Why did I call it CT? The bone is white. Is it NCCT or CCT? What do you see? You can see here that this is the aorta. In front of the CT, whenever you see that the vessel is filled with contrast, that is aorta. Vein is always on the right side. So on the right side, what you see here is IVC, which may or may not be filled with contrast. So we see aorta, IVC, aorta has contrast. So this indeed is a CCT. And then what do you see? These are the kidneys, and you can see that the kidney is meeting in the midline. This is what we call as the isthmus. So isthmus is the fused inferior pole of the horseshoe kidney. We have taken a cut at this point, and this is the appearance we see where the two kidneys are meeting in the midline. Now, what if they ask me not the diagnosis? The diagnosis we know now is horseshoe kidney. They might ask me, what is this tiny little vessel anterior to the isthmus? Be like, ma'am, how can they ask me such a tiny vessel? Do I need to know every single vessel? You don't. This vessel is important because if you know this vessel, you know the pathophysiology of horseshoe kidney. Horseshoe kidney, remember, or all kidneys in general form in the pelvis, right? You know, metanephric blastema gives rise to the kidney parenchyma. It fuses and then it comes up. So the two kidneys are forming in the pelvis and then they rise up. Now imagine this horseshoe kidney trying to come up. Normal kidneys go from the side, not an issue. This horseshoe kidney now is going to encounter the ventral branches of the aorta. The inferior most ventral branch is inferior mesenteric artery. So while my horseshoe kidney is trying to come up, it's going to encounter the IMA, and that's why there is a constant relation between the isthmus and the IMA. Whenever you see a vessel interior to the isthmus, it's got to be inferior mesenteric artery. Did you understand? So that is why a tiny vessel can be asked, because that indirectly tests whether you know how kidneys form or not. So that is what you need to remember, that inferior mesenteric artery is always going to be anterior to the isthmus, right? Which syndrome is horseshoe kidney more commonly associated with? Turner syndrome. So that's another question for you, horseshoe kidney associated with Turner's syndrome. Next, I'm going to show you 4 images which students frequently confuse. All 4 of them very frequently tested as well. So look at the first image. The first image is an abdominal X-ray. What do you observe? We observe that the right kidney, I hope no confusion with right and left at this point. So always this is right, this is left. We observe that the right kidney is completely calcified. It looks as if it is filled with cement. So white, putti cement. So this is what has been called as the putti kidney. This putti kidney is what we see as an end stage. Remember how hydatid as an end stage was completely calcified? Putti kidney is the end stage of genitourinary TB. Once TB has destroyed the kidney completely, the end stage is a completely calcified kidney called as putti kidney. So this is a kidney which has no function left, and that is why this is as good as doing an autonephrectomy. The body has destroyed the kidney. So this is what you see as putti kidney, completely white, calcified kidney, end stage of genitourinary TB. They may describe in the question that the patient has sterile pyuria. Sterile pyuria is a buzzword for TB. It means that there are pus cells, but you don't see the bacteria, which is E. coli in this case because it's tubercular. Alright, so that's putti kidney for you. Now distinguish it from this particular image. In putti kidney, you had a completely calcified kidney, whereas here you can see the calcification is conforming to the collecting system. So what is this big stone here? This is what we call as staghorn calculus. The staghorn calculus occupies the collecting system. Remember, this is usually formed by struvite, right? What is struvite? We have studied that in surgery as well. Struvite is your triple phosphate stones. Okay, so this is your triple phosphate struvite. You remember the coffin lid appearance? It will have this coffin lid appearance of the crystals associated with Proteus infection. Proteus is urease positive, so this is promoted in alkaline pH. These are all of the associated questions you may get from staghorn. Now look at the third X-ray here. Can this be putti kidney? It can't. Putti kidney can't be bilateral. Second, is this staghorn? No. This is where the complete kidney shows me calcification, but it's not the complete kidney as well. It is not even like putti kidney. What's the difference? You can see that now this calcification is occupying the medullary pyramids. Yeah. So when you see bilateral calcification involving the medullary pyramids only, this is what we call as medullary nephrocalcinosis. So this is what is nephrocalcinosis, calcification of the medullary pyramids. This is where the kidneys are functional, okay? This is not like putti kidney where the function is lost. Here the kidneys are functional. It's just that the pyramids have calcium within them. Fine. So that's the first point. Apart from this, what you need to remember, what are the causes? So this can be seen with congenital conditions like medullary sponge kidney, which may show you calcification of the pyramids. The second association you want to remember is any cause of hypercalcemia. Anything like hyperparathyroidism, sarcoidosis can eventually lead to this. So hypercalcemia is a very important consideration you need to keep in mind. Now look at this image. So this is where you are being shown an IVP. They'll mention in the question that there was a delayed IVP which was taken. What can you see here? Look at this. First of all, on the left side, this is what normal collecting system looks like. And now look at the abnormal right side. You can see that the complete kidney is swollen. This is what is called as hydronephrosis. Yeah, the kidney is completely swollen and retaining the contrast. Why? Because there is obstruction at this point. There is obstruction at the level of the pelvi-ureteric junction. This is the renal pelvis, and this is where you're supposed to have the ureter taking the contrast. But here there is an obstruction at this level, resulting in retention of contrast even in delayed images. So this is what is diagnostic of PUGO. PUGO meaning pelvi-ureteric junction obstruction between the junction of the renal pelvis and the ureter. Fine. So this is what is very important to see whether they are mentioning IVP or not. When this question came, a lot of students marked putti kidney and came back. Can it be putti kidney in an IVP? Never. Putti kidney is non-functional. It will not take up the contrast only. So this, if they mention IVP, you have to be very careful. So I've kept the four most confusing images together so that you understand the differences. All right. Moving on to cysts now. So I revealed the answer, but now forget about cysts and see this lesion. First of all, which kidney? Right or left? You can see that there is a lesion in the left kidney. If I ask you what is the diagnosis? A. RCC, B. renal cyst, C. angiomyolipoma, D. all of the above. What do you think should be the answer? You have to see the lesion characteristics. Don't jump to the answer. Look at the color or the density of the lesion. Try and match it with something that you can see from the image itself. Internal reference is always the best. So you can see that, ma'am, this gray color I can see here also. I can see here also. They look exactly the same. So what is common to all three of them? Gallbladder has bile, fluid. Spinal canal has CSF, fluid. So the lesion has fluid. So fluid containing renal mass is a renal cyst. Do you remember Hounsfield Unit 0? This is what that looks like, the gray color. So this is how you diagnose a simple renal cyst. For cysts, when you have septations, you have calcification, you have enhancing component, that is what is called a complex cyst, which may have risk of malignancy, and that is what is the Bosniak classification. Taught that to you in surgery BTR, but here just mentioning the name. So complex cyst is Bosniak classification. Now look at this image. My first question to you is this X-ray, CT, MRI, ultrasound. So what you see, the bone is black. So this indeed is an MRI. On MRI, what do you see? You see that both of the kidneys are enlarged and they have these multiple hyperintense cysts here. So what do you see? This is autosomal dominant polycystic kidney disease. Why autosomal dominant? Why not autosomal recessive? First of all, autosomal recessive polycystic kidney disease is going to be seen in infants, right? This is an adult patient that has been shown to you. These ARPCKD, basically these babies are going to develop CKD by infancy, so they usually die by, young childhood. So that is one point. Apart from that, morphologically, ARPCKD will not have these big cysts. The outer contour in ARPCKD is going to be smooth. Here you can see these multiple large cysts. In ARPCKD, you're going to have a smooth contour. You are going to have these microcysts, small cysts at the corticomedullary junction that we call as microcysts. The cysts are so small that overall, what you see are two very enlarged kidneys and with a very, very echogenic appearance on ultrasound. Forget about that. Just remember that the outer contour is smooth. They are not these big cysts. So if I ask you, can this be ARPCKD? Your answer is going to be no, ma'am. We'll never see these big cysts in ARPCKD. So this is autosomal dominant polycystic kidney disease. Just an IVP image of the same. What will happen? Now the collecting system is trying to navigate through these multiple cysts, isn't it? So this becomes very, very plate and kind of looks like a spider leg. So this is the spider leg sign on IVP of polycystic kidney disease. Not just that, if you do a nephrogram, it may show you the Swiss cheese appearance. So just remember these two names in context of autosomal dominant polycystic kidney disease, right? So this is all about renal cysts. Very, very important. Let's talk about renal masses now. So there are three main masses, three features, three syndromes. The first one, right kidney, what do you see? You see that there is a very heterogeneous mass which shows a lot of necrosis within. Whenever you see such a heterogeneous necrotic mass lesion, this is the most common RCC. This is clear cell RCC. So this is the most common RCC, clear cell RCC. Histopath, just to correlate and finish it right here, right now. Why the name clear cell? Because this has the presence of glycogen and lipid within the cells, giving them this clear appearance. Clear cell RCC is associated with a syndrome. Can you name the syndrome? If I tell you this patient has cerebellar hemangioblastoma, pheochromocytoma, what is this syndrome? This is VHL, von Hippel-Lindau, clear cell RCC, hemangioblastoma, pheochromocytoma, 3 letter of VHL, chromosome 3p. So that's clear cell RCC. Look at the next image. Can you see that there is a mass lesion and the feature is there is a central stellate scar? So when you see a mass lesion with a central stellate scar, what is the diagnosis? So here the diagnosis becomes either an oncocytoma. If this is not in the option, go for chromophobe RCC. So oncocytoma or chromophobe RCC, central stellate scar. And what you see here are these plant cells. This is what has been likened to plant cell containing chlorophyll, and they call this as racinoid nucleus. So this is oncocytoma, chromophobe RCC syndrome with this. If you have a person with a mass lesion in the kidney, lung cysts, fibrofolliculoma, they'll show you face of a patient with follicular based lesions. What is this syndrome? This is Birt-Hogg-Dube syndrome. So this is Birt-Hogg-Dube syndrome. It is associated with a mutation of folliculin gene. So this is oncocytoma. The third mass lesion where you now see the characteristics, and again we said internal reference when in doubt. You can see this lesion is black. We said only two things have a negative Hounsfield unit. Either it's fat or it's air. Yeah. So it has to be one of these. Internal reference, this is the air density, black. This is the fat density, subcutaneous fat. Can you see how it is not as black as air, but as black as fat? Meaning this is a renal mass containing fat. What is it? So there's only one mass containing fat. This is angiomyolipoma of the kidney. You can read the word. It will be right there staring at you in the options. When you hear the word fat, think black on CT. So black on CT, negative Hounsfield unit is angiomyolipoma. Which syndrome will you rule out? If I tell you the patient has seizures, adenoma sebaceum, again face will be shown with these lesions. What is it? It is tuberous sclerosis. So tuberous sclerosis is associated with renal angiomyolipoma. Now, this is actually a hematoma, right? You know, in tuberous sclerosis, you have chromosome 9 and 16, hematin and tuberin genes being mutated. So there are various hematomas. Hematoma of blood vessel. Anything where blood vessels are hematomatous can bleed and lead to retroperitoneal hemorrhage, and that syndrome is called as Wunderlich syndrome. So that is what you want to remember. A ruptured AML can lead to Wunderlich syndrome. Fine. Just 2 extra scores for you. Renal score, you'll study this. We'll study this in BTR as well. Renal score is a score used to determine whether partial nephrectomy may be done or not. The procedure, surgery of choice for renal masses is partial nephrectomy. The radiological score to determine whether a mass is suitable to do so is the renal score. And Bosniak grading, as we said, is for complexes to assess their risk of malignancy, right? So this is all about the renal masses. Now, just as an extension of the point that you know fat, Look at this lesion. So this is a young 20-year-old female who's come to you with distended abdomen, pain abdomen, and this is the CT. So we're down at the level of the pelvis. You can see that from the SI joints. You can see the sacroiliac joint. So we're down in the pelvis, and can you appreciate there is a mass lesion which has what? Which has fat. You also recognize white of calcium. When you see a mass lesion in the pelvis with multiple germ cell derivatives, fat hai, calcium hai, soft tissue hai, what is it? This is what is a dermoid cyst. A dermoid cyst, also referred to as a mature teratoma. So in a female, young female, the most common germ cell tumor that you have is a mature teratoma or a dermoid cyst, and this is the radiological hallmark where you see fat and calcium within it. Right? Now we move on to very important, a discussion of the next investigation that a lot of students confuse, that is MCU. MCU stands for micturating cystourethropy. Micturating cystourethropy. So now understand what we are doing. You put a Foley's catheter in a patient, and then you are going to inject around 300 to 400 ml of contrast, iodinated contrast, which we dilute with saline. Once you inject 300 to 400 ml, now the patient is going to say that I'm having this sensation of fullness and I want to void. So now you ask the patient, you remove the Foley's and you ask the patient to void. When the patient is voiding or micturating, that is when I take an X-ray. So when you take an X-ray while the patient micturates or voids, you're going to see something like this. So micturating, cysto meaning bladder, urethra meaning urethra. So this is where we filled the bladder with contrast. So the bladder is distended, patient is micturating, so the urethra gets visualized as filled with contrast. Did you understand this? So that is the procedure of MCU. Just to highlight the anatomy, you can see this is the urinary bladder. This part here is what is called as the posterior urethra. It consists of the prostatic urethra within the prostate and a very small part of membranous urethra. So prostatic membranous make up the posterior urethra. Then this most distensible part that you see here, this is what is the bulbar urethra. Okay, so this part here is what we refer to as the bulbar urethra, and this within the penile shaft is the penile urethra. So together, bulbar and penile make up the anterior urethra. So this is the anterior, whereas membranous prostatic make up the posterior urethra. That's the urethral anatomy there. Now, MCU is going to be very useful. It's the investigation of choice for two conditions. Look at the first patient here. This is a young child who has come to you with recurrent UTI. So when you have recurrent UTI in a child, what is the diagnosis? The most common cause of recurrent UTI in children, and this is reflux, vesico-ureteric reflux. What does it mean? Look at the MCU. We were supposed to see the urethra when the child micturates, but what do you see instead? You see instead that the contrast is going back into the kidneys, meaning this is where the contrast is refluxing back into the ureters. So this is vesico-ureteric reflux. There are 5 grades to VUR. So grade 1 is when you only are gonna see the ureter. So if you only see the ureter, this is what we call as grade 1 VUR. Grade 2 VUR is when you see non-dilated ureter and the kidney. 3 is where you see mild dilatation. So that is when now you are going to see mild dilatation of the ureter and the kidney. 4 and 5 is where you have severe dilatation. What is the difference? In 5, you are going to have this ballooning. Okay, so this is where the difference comes. Look at number 4. In number 4, there is a lot of dilatation, but the papillae impressions are maintained. So this is where the papillary impressions are maintained. In 5, those papillary impressions are lost and you can see this outward bulge now. That is what is called as ballooning. Here it is still inward. So that's the difference between 4 and 5. They'll not ask you so much depth, but at least 5 you should be able to recognize. Can you see this gross ballooning outwards? So this is grade 5 VUR right here. So this is what we need to know, that for VUR, what is the investigation of choice? It is MCU. Another condition where MCU is the investigation of choice. Now this is where a child comes to you with dribbling of urine. This is the most common cause of congenital urinary obstruction. So this may present in utero as well in very, very severe cases, but most of the time it's going to present after birth as this dribbling of urine or a poor urinary stream. So what is the cause? What is the diagnosis? You did the MCU, you can see this is the bladder, and now the posterior urethra you can see is dilated, and then the anterior urethra is almost not visualized. So this means there is some obstruction here. So what is that? That is a posterior urethral valve. There is